last time we decided that we should discuss on OCT imaging and orbital atherectomy. So many of us are already doing it and they are experts in their field. Despite that, I thought we always think, and this is our understanding, that when we call a visiting person, we also get a different perspective of what people in the other parts of the country are doing. So we have called 2 high volume operators from outside Mumbai just for us to discuss with them, understand what new things or something different they are doing, and discuss, reason out and learn for everybody. So I am sure the chairpersons which we have selected and the moderators have enough experience in the same procedures. So let us all together discuss this. Now the first person to speak is our own person, Dr. Ronnie Matthew. I am proud to say that once upon a time he was my student, but today I am going to learn from him, and I am proud about that. It's a privilege to learn from your own colleagues who have come up from as a student to this level. So he is now an international personality to the best of my understanding. He has been presenting in all major conferences like TCT, European Bifurcation Club, and have you PCR. And it's a really pleasure to see somebody growing to this extent and being appreciated all over the world. So I won't go into his biodata because we won't have any time to make the presentation. So I will request Ronnie to start his presentation on how OCT has helped him, and let's discuss and see if we can benefit from whatever he is going to tell us. Thank you very much, Ronnie. Yeah, before that I'll ask Amit. Where is Amit? Amit, can you take over, announce the chairpersons and this, and also request that chairpersons can sit there and listen and then come here for discussion because they may not be able to see the screen. Yeah.
Hi, good morning. So I think we should start this because we need some time for discussion after every presentation. I would also request all the presenters who are going to present cases to see if we can, I know imaging and orbital atherectomy cases are pretty long because, to run OCT images and the videos takes a long time. But if we can finish it in, with a reasonable time, 10 to 12 minutes, then we'll have some time for discussion. So for the first session, I would like to request, I think Dr. Ajit Menon sir is not here. So Dr. Ganesh Kumar sir, Dr. Hasmukh Rawat sir, and Dr. Anil Poddar sir to come up as the chairpersons, I think once for discussion later on. Okay. Dr. VK Shah sir, yeah. And Amit Sharma is not here. I think he'll be reaching in few minutes. Ashish is here. So I think once sir finishes her presentation, if you can just come up and we can have some discussion. Thank you, Dr. Ronnie Matthew sir.
Okay. Thank you, sir, for the kind words, and it's always a pleasure to be back in Mumbai. It's like coming home. And as sir said, today is really an honor and a pleasure for me to be here, doubly because 2 people who made my career are both here. When I was in KEM as an MD student, Professor Yevlekar was my teacher, and he's here, and I'm thankful to him. And Dr. Kane, who was my teacher for my DM at Csi. Both of them immensely contributed to my career, and my pranams to both of them. So today I'll be talking about OCT, and you can stop me whenever you have any doubts, and I'm going to go more into the practical aspects rather than teach you about the physics and interpretation, which I think most of you have already done. So let us go to this first patient of ours. So this is how I believe everybody should approach a patient when you're doing intervention with an OCT. So this is a typical patient of ours who is diabetic, hypertensive, etc. Now this is his baseline angiogram. So you see the angiogram, you see there's an LED going on, and in this LED there's some amount of calcium that you can see, and the lesion appears over here. So let's see how OCT helps us in this particular case. The first thing with OCT is how you're going to strategize how you are going to take this case. So you look at the morphology and you look at the sizing. So now, when you go to the morphology and the sizing, that's the first thing you do. You do an OCT run And once you do the OCT run, the first thing that comes is the morphology. You can see it on top over here, the morphology. And the morphology at the moment is basically to catch calcium, because that is where our device strategy takes place. So this tells you that there's calcium because this is co-registered. And you see this orange bars here, it tells you there's calcium. What is the amount of calcium that you want detected depends on how you set it into the device. And basically on the L view, you see calcium here. You know there's calcium. So in morphology, there's calcium. Do you want to use a device? What device you're going to use? I think Girish will talk to you about that. But basically, for me, if the angle of calcium is less than 270, I generally don't use a device. We use a balloon or balloon sort of systems. So having known this, that we don't have much of calcium, but we can modify it easily, you select your device. Just to go a little bit into calcium, because this is an important topic. We have three types of calcium, as you see. Deep calcium, that's deep, when you've got a fibrous tissue between the lumen and the calcium. Superficial calcium, when it's all around, and this is nodular calcium. Now, calcium you can make out because they have boundaries. But I think when we go deeper into discussion, we'll talk about other forms of calcium that don't have boundaries. Now, the third part of calcium that I told you about. Now, there are two types of actual nodular calcium. What we call as eruptive, that's this, and nodular. What is the difference between the two? The difference is that this causes acute coronary syndrome. That causes MI. And these are two different animals completely. It's not the same. And that's why you require an OCT to find this out. Because if you have got an eruptive calcific nodule, you don't need all your fancy rotablation and IVL and things like that, because you can deform very easily. You can easily go and put a stent. The problem is that it comes back. The recurrence is high. On the other hand, nodular calcium, you will need some device, but the advantage is it doesn't come back. The advantage of OCT in calcium is this. You can know the thickness of calcium, you can know what is the arc of calcium, you can know the length of calcium. Very easily defined, and that is where it scores over intravascular ultrasound. And now, with a simple algorithm, and this is something that I use very commonly. You see on the L view, you can see calcium. But if you have calcium greater than 270 and its length is long, I think you need a device. If you don't use a device, you're not going to be able to implant a stent and expand it well. The third part, the minimum thickness, is very important, because if you have a less than 3 millimeter, 0.3 mm, 300 microns of calcium, you can very easily break it with balloon. So if you've got calcium all around, but you've got some area thickness is less, just use a balloon. You can do that. And importantly, you can confirm your calcium modification. See, when you use an IVL, you see these cracks in calcium. When you use an orbital atherectomy, you can see the sanding of calcium, as you see over here. And of course, the rotablator, you can see the burr. It has cut through calcium and burred it, so that you can go and expand it. So in our case, I decided to use a cutting balloon, because it really did not have all that form of calcium. So we use a Wolverine balloon, and after Wolverine, it looks nice. Now, how does OCT help? Now, once you have done the preparation, you have to decide what is going to be a stent length and your stent diameter. And that is where the sizing tab comes in. The sizing tab automatically decides what should be your average. But you can say that, no, this is not what I want. You can go and decide, and you can go to the proximal edge, you can move the proximal edge. So this is the stent that has been decided by the Ultreon, but you can decide where you want it. In the sense, it automatically tells you this is the external elastic lumina, and you have an elastic lumina here of 4. Distally also you can move it, and you can come back to a place where you think is more or less where you want the landing zones to be. And remember, in the landing zones, is very important that you have less than 50% of plaque burden, not much of lipid, because if you land your stent in lipid, you're going to get a restenosis. And how are you going to size the stent? Very simple. If you have an EL over here, it says 4, the stent should be 3.5. If you got over here a lumen diameter of around 2.6, step it up to 2.75. Lumen, step up, EL, step down. So, in this case, ideally, you've got a long stent. If the patient has money, you put in 2 stents. My patients generally don't have money. So, I decided to go and put a 2.75 48 millimeter stent, because with one stent I can do the job. So, I implant the stent. Looks to be a decent, good result on that stent. Now, we have put in the stent and we come to the next part of it. Have we put in the stent well? Because that's going to tell you the long-term results. And that's called optimization. So for optimization, you run the second OCT run after the stent, and let us see. These are the optimization parameters that I want you to remember. Your expansion should be at least greater than 80% of your average lumen diameter, which again is told by the machine automatically to you. Malapposition, there are criteria of greater than 0.4 millimeters. Again, automatically it tells you. How does it automatically tell you? On this view here, on the angiogram, you can see the stent that's been implanted. Again, AI has told you about that. You see orange over here. I think you can see the orange there. You can see an orange here. This tells you the stent is malapposed. Inside the lumen over here, you see dark orange. That tells you it's under expanded. So you got more work to do. Malapposition. You see the stent over here, malapposed. It's not reached the lumen. And that's malapposition. And at this point, it's not expanded well. So if you leave the stent like this, you're going to get restenosis. So malapposition, you're going to correct it. How are you going to correct it? Simple. Over here, you see the lumen is 3.36. Step it up. Take a 3.5 balloon and correct your malapposition. Expansion, over here, again, you see the expansion here is only 68%. What is your lumen? 2.5. Step it up, 3 millimeter balloon. And do that, and you have finished your work. And that's the final result. So, what you have achieved is all the 3 parameters you have achieved, and you have optimized your stent perfectly. And this has just taken about 30 minutes. So that's how you can actually use your OCT in your daily practice. And this is how I think is a game changer. If we do that, we're going to beat the surgeons with the left internal mammary artery. I think that's, the reason we are doing all this is basically to be as good as the internal mammary artery. Now, based on for so many years, so the work that has been done on optical coherence tomography and intravascular ultrasound, now we have a recommendation. A 1A recommendation that you should be using this in all your complex lesions, in your bifurcations, in your left mains, and your calcified lesions. And the reason we use is this. All the reasons that I've sent, you can get your automatic vessel sizing, as I showed you. It tells you the landing zones. It tells you under expansion, malapposition. It tells you the host of things that makes you do a perfect angioplasty. Now I'll talk a little bit about bifurcations, because that's my real area of interest. The reason OCT helps you in bifurcation is, remember, bifurcations like this, you see here. There's a lot of overlap, foreshortening, because coronary artery is actually a 3-dimensional structure, and what you're seeing is 2 dimensions. So OCT will take you into your longitudinal view, it tells you into your cross-sectional view, and then importantly, 3-dimensionally, it opens the artery up for you, and you can see your side branch ostium, how the ostiums are. And this has shown by data. Data tells you, as the October trial did, that there is, if you use optical coherence tomography in your bifurcations, you cut down your MACE by nearly 40%. Now, one of the areas is this wire management. For example, I put a stent here from the circumflex to the left main, and I'm trying to do a distal cross. You know you have to do a distal cross when you do a provisional stenting. The reason I will tell you right now. So if you look at this, rerunning this, this is how you do a distal cross. Come there and you push the wire in the moment it comes distally. And this is how we used to always practice this. And we think that's a distal cross. But look at it, what's actually happened. Now this is the left main, this is the LAD. These are the struts. So your wire is actually crossed proximally. Now, if you go here and inflate the balloon, what's going to happen is all these struts are going to remain at the carina here. And that will be a cause for your stent thrombosis later. So what you got to do in this case is take it back and recross it, confirm your distally. Now you're distally. And only when you're here and you do your kissing balloon will you get a result that looks like this. There is no strut across the side branch, and that's very important. You look at this. Now here, this is the proximal, this is the distal. You look at this wire, it has gone distally. You can make that out. And the advantage is the moment you go distally, these struts are pushed onto the side branch wall, scaffolds it, instead of being a problem for you and a problem for stent thrombosis. And the thing is, this is important. A lot of people say it's very difficult to do this. Now look at this case. We have got fenestrated restenosis when we have left struts in the side branch ostium, and we have got 12 cases so far. In this particular case, you see, we've done a beautiful stenting. The circumflex ostium looks very nice, but 36 months later it comes with angina. And if you look at that, see, this is a stent there, and the stent across the ostium, all the struts have grown neointima. This is called fenestrated restenosis. And you integrate physiology into this, you find out that area is ischemic. And you've got to do something about that. And all the ischemia comes from the ostium. Now, another case, LAD cipher stent that was implanted 10 years ago. He has angina, looks very good, but if you look at the circumflex ostium, there's a problem there. And you can make that out on OCT. As it comes across here, you can see the ostium coming and struts across the ostium. At this point, you see this? And you can make that out in different views. You can go into your fly-through, and as it comes here, you can see the circumflex ostium divided into 3 small holes by intima growing into the struts. That's about side branch. The other thing is 3D capability, of bifurcation. This case, he's got a LAD, a ramus, and a circumflex. And somebody implanted a stent there into the LAD. You look at the amount of struts that are lying into the left main. 1, 2, 3, 4. 4 set of struts. You can't make that on an angiogram. So this bifurcation view helps you to understand it. And this sort of understanding, we have only got it recently after the October trial, and we call it the unintended stent deformation. Now, what is unintended stent deformation? This is something again that I want to tell you. It happens when you do a left main stenting very commonly. And unintended stent deformation is seen apparently in 18% of cases, all cases. But if you look at left main, it's seen in a larger number of left main cases. Now, what exactly is unintended stent deformation? One is when you put in a stent and you got an area between the stent and the wall, and then you rewire it. We call it abluminal wiring. Once you rewire it and then you put another stent through, the proximal stent gets deformed completely. I'll show you a case of that. Longitudinal compression. Your guide will go and hit the stent over there and compress the stent. Similarly, there are other mechanisms. The reason why I told you this is that before we understood about USD, in about 45% of cases, we never detected that. It was detected in the core lab. And if you detected it and you treated that, you had no MACE. But if you left that problem around, you had a MACE of 23%. So again, understanding USD, looking for it, treating it has become very important. Now this is one case that I wanted to show you again here. It happens. We have put in a stent, we have opened that, and then we are trying to put a stent across into the ramus. The stent doesn't go in. You pull, you hitch, you do all those things to get your stent inside. Now what happens is, look at this. The stent in the left main got compressed and you have a crowded strut over here. This is called longitudinal compression. Now, this is a patient who came with an MI. His lesion is over here. But he had an earlier stent put about years back in the proximal segment, and nobody could wire this and take a balloon there. And we didn't know the reason. The reason was this. As you see, you look at the earlier stent, it was under-deployed, malapposed, and the problem is, you see the proximal stent, when they tried, the wire was between the stent and the wall, not inside the stent. And you deform this stent over here. And because of this, you can't take another stent distally. So you got to first sort this problem out before you go with the next thing. Now, this was a case of under-expansion with abdominal wiring. So when you got a proximal stent done years back, you got to be very careful when you have a distal lesion now. Try and approach that a little carefully. Now, this is again a very simple ostial LAD stent. We did that. We thought the result was good. We pulled out everything. Last shot, you look at the proximal LAD here after stent implantation, and here. Something is not right in this proximal LAD. So again here, we ran an OCT again. And what you see over here is, this stent that was there in the proximal LAD has got pulled into the left main. I'll show you a little better. You see the stent? It's got pulled into the left main. Maybe some balloon or something just hitched it and pulled it out. You never realized it. So, look at that. Stent over here, okay. Stent over here, pulled right across the circumflex into the left main. This is called the longitudinal stent stretch. And again you got to correct this, because you push this patient to the CCU, he's going to get a stent thrombosis and he's going to arrest over there, and you never knew what actually happened. Now this is the case that I showed you. This is called the ostial nailing conundrum, because everybody, now this here, he has come with an acute MI, he has got a lesion in the LAD, he has got a lesion in the ramus, he has also got a lesion in the circumflex. So here, so my colleague did this late at night, so he did a perfect ostial LAD stenting. He said, I'm going to do a perfect ostial LAD stenting. So there, he has perfectly put an LAD ostial stent, and result looks nice. Send him back to the room. Next day we come for stage stenting of this ramus and circumflex. And you look, this is the picture that I showed you earlier. That stent that was supposed to be right at the ostium here has come back by a few millimeters, and that is troubling your circumflex and your ramus ostium. Now correcting this is a nightmare, because now you have to go through this stent, deploy the stent completely, go through both of this, and then put 2 additional stents in. So that, so you have a stent hanging over here. So I'm not going to go into what we did, but we did a lot in this. Spent about 2 hours trying to correct that, and then we did this is the final result that we got. You see in the 3D bifurcation view, we have removed some struts out, but we have not got a perfect result. So again here, prevention. This is the best that you can get. You look at this, that's a 2 openings, circumflex and ramus. This is the LAD. We've done a decent job, but you see all this metal. This is what I was initially terming as the metallic neocarina, which can cause thrombus to come in. This is also another very interesting case. This is a 34-year-old male, came with an anterior wall MI. He was in Dubai, and they implanted a stent here. A very simple stent into the LAD. Got a good result. The problem was, 6 days later, he had a re-STMI over there, and they found that there was some thrombus. At least at this point, you must go and image and see what's going wrong. But of course, they put in another stent, just distally. The problem was he was getting recurrent angina. So now we evaluate him for this recurrent angina to see what's going on. So on the angiogram, everything looks good, but why is he getting angina? Actually, the angiogram itself will tell you. If you look at the left main, you look at the stent in the left main, it's lying right across here. Nobody has realized it. This was the first stent that was implanted. So when they probably put the second stent in, they went like this, abdominally, and deformed the stent. And when we put the OCT, we saw the same thing. The proximal stent, you look at this, all this under-deployed, the stent is really not touching the wall, it's malapposed over there, And as you come more and more proximally, you see this strut is outside, stent is outside, and your wire is outside the stent. That's the stent there. There's space between the stent and the wall. The stent is outside, your wire is outside. And they have gone through the side of the stent and entered the stent. This is a nightmare because now you cannot go and wire through that stent because the stent is deformed. We spent about 2-3 hours trying to get our new wire through this. We just couldn't. Multiple wiring, multiple stenting, we couldn't. So what we did is, we just went and plastered that undeployed stent onto the vessel wall. But again, the problem with plastering is, even after you plaster it, you will still see that it is not plastered well. You still have one side of the stent over here, one side of the stent over here. And this is the circumflex ostium. Now we are impinging on the circumflex ostium also. That's how it looks. The stent is impinged onto the circumflex. Though angiography, it looks very well. So we did serial kisses, trying to somehow oppose that stent onto the wall. And it's not easy doing that on a roomy left main. And at the end, we got this result which we thought was pretty good. See, the stent is on the wall, and we have got a roomy left main. And that's how the OCT looks like. 2 wires, circumflex ostium, the stent right over there. And I was always worried about him. 6 months later, we got him. So this time we said we must do another OCT to see what's happening to that left main stent which we compressed and other things. And you look at the stent, it looks pretty nice, over there. It's walled off. Neo-intima has come inside. And if you look at the 3D picture, you look at that stent over here, lying there with all the neo-intima that has formed. Now we're not worried because he's not going to get a stent thrombosis. And if you look at this view here, you can see the stent over here, no stent over here, and then the stent comes in because that part of the stent was compressed onto one particular part of the wall. So this was some snapshots of OCT that I wanted to give you in this last half an hour. And I think the future of OCT is even going to get better because now we are going to go into this Ultreon 3. It's going to be there the next year. And not only are we going to AI detect calcium, we are going to detect lipids. And AI is going to tell you a virtual physiology, what we call as a VFR, a virtual fractional flow reserve. And it will be a faster pullback, a faster acquisition. So as I showed earlier, it is not going to be MLD max, it's not going to be morphology, length and diameter, it will be morphology with physiology. It will not only tell you where the lesion is, it will also tell you what your virtual fractional flow reserve is. You can do that, and at the end of it, do another OCT run and see that your physiology is good. So not only are you going to anatomically correct it, you're going to probably be sure physiologically it is right. So I'll stop over here. I think 30 minutes is over. And I'll be glad to take any questions. Thank you.
So can we have the chairpersons, please, so we can have some discussion, and the moderators? Amit Sharma is here, Dr. V.K. Shah. Please, if you can come up.
Yeah, tell me.
Excellent cases and beautiful demonstration. It shows how the imaging, especially the OCT, nowadays helps, Couple of good cases. Just 1 or 2 questions. You think the cost is prohibitive for this particular modality. So you have the specific indication where you will definitely use. Because given choice, everybody would like to use the imaging for every patient, but cost is prohibitive. So can you summarize where you should use it? Obviously, when you found such problems in the left main stent hanging, all the things, it is must. But apart from there, can you give some guidelines or some indication one must use it?
Yeah, no, I do agree with you. But I think cost is more a problem for us in the south than it is in Mumbai because, an OCT catheter costs only 60,000 rupees. So, I mean, considering the cost of your angioplasty package.
Cost varies from place to place. In corporate, it's only MRP. You know what is MRP. So,
okay.
Yeah.
Yeah, so I would still say that considering the cost of an angioplasty, doing an angioplasty more perfectly justifies the cost. But again, there's no point doing OCT in all cases. You don't need it. You're going to do OCT, as I said, when you're going to put a stent into the ostium, to be sure you've done it correctly. I think left main ostium, mandatory. I mean, it may be a little provocative to say that, but I don't think one should do a left main angioplasty if you do not have intravascular ultrasound or OCT. It's just not right for the patient. Bifurcations. Calcium. See, calcium modification tools are expensive. When should you be using an IVL? When should you be using a rota? When should you be using an orbital atherectomy? OCT will tell you. See, once you do an OCT, in a good number of cases, you don't need any of these tools because you know you're going to get a stent expanded well once you see where the calcium is. So, I think these are some of the instances where I think you should be using an OCT. When you've got a doubt in your mind, have you done it right? And especially if you want to sleep well at night. You do a case with an OCT, you're sure you're going to sleep well at night. You're not going to get called at night.
One important indication is the long stents, when you're using the long stents.
Yeah, long stents.
Probably abroad the Medicare pays only if you are using the long stent, not for the short stent. So probably if you are using more than 36 millimeter, that's Australian standards, you should use the OCT and they pay you, otherwise they don't pay. So long stent one must be especially 48. Especially long stent with a smaller size is a must, to get a good idea. Otherwise patient will definitely come back. Right. Ganesh?
So, Ronnie, in my practice, we have both OCT and IVUS. So, the Ultron 2 especially is the one where I use in all calcified lesions because it helps us to decide on the strategy.
Perfect.
So, we decide like if the thickness is say less than 750, between 500 to 750, sometimes up to 800 or 900, we use a cutting balloon. Anything more than 750, 800, we have to use a modifiable device. So, I mean, it helps you to actually, like you showed, what device needs to be used. So, for calcium, I think there is no substitute for OCT. I mean, IVUS is far away from OCT as far as calcium is concerned. As far as left main is concerned, I personally feel IVUS scores over OCT because it's hard to image the left main with a guiding sitting there. Even ostium, I mean, you can use an IVUS and get away with it. So for me, I think OCT will be in all calcified cases where it helps me to start the case with what particular device we'll use, and rest everywhere else, I think I get away with an IVUS.
Yeah, yes, Ganesh. I think a very practical and a very prudent thought process. I think for ostial left main, I also entirely agree with you. I think intravascular ultrasound scores. But the importance is imaging.
Yeah.
Get them to image it. Whether you use OCT or IVUS, image it. But I think very good points on that calcium. Cutting balloon up to 600, 700 microns and only use the others when it's more than that. Yeah.
Yeah, excellent talk, sir. About bifurcation, if suppose OCT is not available, after going through so many OCTs, what is your practical advice who don't have OCT, if we learn from OCT and we apply that?
Yeah, I think this is something that has been discussed a long time. IVUS eyes, you call it, OCT eyes. That is, once you've done an OCT and then you don't require an OCT, I somehow don't agree with that. I think if you've got an OCT, use it. Because, I think your preparation, that is, as I said, strategizing is much better. Optimization is much better. You can be 100% sure that you've done a good job.
Can I answer that question? I mean, 3 problems that you showed. One was the longitudinal stretch.
Yes.
So the answer for that is when we do a pot, and if there is a big mismatch between the proximal and the distal, try doing the pot proximal and then go to the distal. The problem is when we do a pot in the distal, and when we are in a hurry to pull it back,
We pull it out.
we stretch the stent. So for example, there is a long left main, and left main is 5 mm in size, and there is a 3.5 stent. If we do a pot in the distal left main, it has opened the left main stent, and then when you suddenly pull the non-compliant balloon, the stent has expanded to 5 in the distal left main, proximal is still 3.5. So you're pulling a 5 mm balloon back, you'll stretch the stent. So that's I mean, very practical thing that we should do. Second thing is many operators try to nail the ostium of the left main, LAD.
LAD should
I
not.
think that thing should be given up and people should liberally put it across the left main and do a pot. So you will not end up with that complication that we keep on seeing, trying to nail the ostium. So,
And what you said very important. And another point is that, you know, in the sense when you, in case you do nail the ostium, and as Ganesh said, proximally dilate the stent first. Because, you know, we've been taught initially that when you take a balloon for post-dilatation, go distally first and then dilate and come back. The problem is when you do that, the stent also elongates a little bit. And now we have bench studies to show you that even if you kept the stent at a particular point, at the ostium, once you do this distal to proximal dilatation, the stent moves up to 3 millimeters. So as he said, first the proximal dilatation and then go distally. I think we are relearning a lot of the angioplasty that was taught to us based on what we have seen here.
absolutely. And the third one that you showed is not able to oppose the stent despite going very high pressure with a non-compliant balloon, especially where the stent collapsed and you wanted to. So what helps there, we forgot, we are now forgetting, we don't use a compliant balloon, anymore. So we should have large size compliant balloons in the lab. So what happens is, suppose there is a 3.5 stent in a 5 mm left main, and you are not able to take a 4.5 or a 4 mm non-compliant balloon into the LAD because of the fear of overdoing in the LAD. But if you take a compliant balloon of say 4 mm or a 3.5 mm and go a little high pressure, because of compliance, the left main will open up, while the LAD will remain at 3.5. So that's how it's easy to oppose. So most of the times we struggle to expand a 3.5 mm stent in a 4.5 mm LMCA with half the balloon in the LAD and half the balloon in the left main with a non-compliant balloon. So we should start using compliant balloons there.
Yeah, perfectly point taken. Because again, as he said, you know, to expand a stent, you don't require high pressure. A stent is a small metal. You just require, you know, soft, non-compliant balloons. The problem is we don't have non-compliant balloons at 5 millimeters. And 5. To oppose a stent with a plaque, you require high pressure. But if you have a left main that does not have a plaque and you just want to expand the stent to prevent malapposition, you require low pressure compliant balloons to just oppose it, because the stent metal will just go up.
Yeah, Ganesh, regarding that ostial nailing that you are told, it's very correct, you know, because more than 2/3 of the patients will have left main distal stenosis, and nailing the ostium is always impossible because ostium of LAD is not a horizontal structure, so you will always miss one edge of it. Secondly, it has been found that whenever you do this particular IVUS, there's a finding called eyebrow sign, you know. So this eyebrow sign shows that it is a harbinger for future ISR as well as subacute thrombosis in this patient. So ostial nailing should always be avoided and should be plastered to the left main. So you should always do a crossover stenting in these patients, you know. There's a very beautiful paper on this in Spain, you know, by Rita Gelli and all, who have studied almost consecutively 78 patients and have discovered this sign. And from there on, people have stopped nailing the ostium, you know.
What is that sign?
Eyebrow sign.
No, I tell you, eyebrow sign is basically for the side branch. Like, you know, if you have a side branch that comes as an angle, there's no diagram here. Main vessel, side branch coming at an angle. So now you look at it. This carina is going to be like that, and the left main is going to be here. So when you put a stent here and expand it, this carina will from here go like that, and this will occlude the side branch. So when you have an eyebrow sign, protect your side branch. Otherwise your side branch will close.
Almost parallel.
Okay.
No drawing.
No, on the
Narrow angle side branch. It's generally seen narrow angle.
So just one question.
Go ahead.
Ajit.
It is the,
Dr.
Ronnie,
Kirti,
it is the formation
can you
of
come in front? We wanted your opinion also.
intimal
Can you please
proliferation in that floating
Dr. Kirti,
stents, which
come
produces
right in
that eyebrow sign in the left main, when it is overhanging. So, and that becomes a harbinger for stent thrombosis and ISR.
Come here, come here.
Yeah, in the side branch.
Yeah.
Ajit.
Yeah, Ronnie, wonderful.
Ajit,
Just elaborating what Ganesh said, the penetration of an OCT is best up to 4 millimeters,
Yeah.
as per the science. So in left main, where the diameter is usually more than 4 millimeters, I think IVUS scores over.
Scores, yeah.
Absolutely scores over. The second thing is that the OCT is very good as far as the wiring side is concerned. No question of. As far as is concerned, as Ganesh has said, I think IVUS should be more in use as compared to the OCT.
Yeah, agree with you. When you want to see the stent strut, when you want to see the wiring, when you want to see thrombus, when you want to see dissections, these are all things OCT will help you. If you want to see the wall, outside the wall, EL, ostium, IVUS is better.
Yeah, I just wanted Dr. Kirti, he is here, he has a very large experience in IVUS and OCT. So just your opinion on what is going on, and you have any suggestions?
Kirti,
I mean, what's the question?
No. IVUS versus OCT. When do you use IVUS? When do you use OCT? But Kirti uses IVUS.
So, I'm a very IVUS biased guy. So, I don't see the. So when I'm doing a lesion closer to the guiding catheter, then I don't prefer OCTs, because if I were to cause a dissection and then do high pressure injections, one of my biggest fear is propagation of intramural hematomas, and therefore these high pressure infusions in the coronary artery kind of make a little bit of a scare thought for me. So left main, guiding catheter going all the way deep seated into the left main, doing an ostial LED are a no-no for me. And I don't see how OCT gives me more information than IVUS really. There are only few things we look at. Landing zones, which are great with both. Definition of plaque, which are great with both. I heard Ganesh talk about thickness of calcium, but practically speaking, I've never measured thickness of calcium in my practice at all. I want to know whether it's superficial or deep. And there are only 4 tools to modify it ablatively, and there are only 4 tools to expand them. So you just need to decide the order of the tools you're going to use, and there are certain calciums. Whatever you do, 15% are not going to work. So,
No.
Yeah, so
I will not argue with you at all, because Kirti is a champion in this, and Kirti has been using IVUS. I've learned a lot of IVUS from him, especially in the left main. Would not argue with you on that at all.
But OCT has its own charm. Like when you go distally down a little bit in the modalities and all that, I think the information it gives us is fantastic. They're complementary imaging tools, and one should use what they are comfortable with, really.
See, the real test of any modality, to the best of me, comes when there is competition.
Yeah.
So then you really determine which place you will use this and which place you will use that. So that's always will remain. So let's go ahead, because we can go on discussion. Thank you very much, all chairperson. No, sorry. We are having the presentations now. Sorry. Yeah, you can sit here. Ronnie, please come here. Bhavesh, as a token of appreciation for Ronnie having flown all the way from Cochin through Mumbai CSI branch, Ronnie, please come here. We would just like to give him a token of appreciation. Come.
Morning. These are, just want to show you some presentations on the use of, we are, unlike Kirti, we are OCT users, so. Though I think eventually it depends upon your ease of, and where are you happy doing a proper interpretation of the images, and what comfort levels you have in either of these. So most of these are OCT guided. So this is basically a 50-year-old guy. Then this was done about June 2019. And this was, he had a CT angio which showed a totally occluded LED, and he came to us with this, and this was the angiographic finding. he told him, because of the anatomic, this thing we said, go for surgery as the first option. But he flatly refused. So then we decided that we will first look at the imaging and see what is the status of the ramus, and the ramus was significant on the OCT. So we had to treat the ramus also. The circumflex ostium looked to be quite clean, nothing much in the circumflex ostium, and actually this was done by Dr. Matthews, not me. So this was, we decided that we will treat the LAD first, and then take the, he decided to do a V-stenting of the LAD ostium and the ramus ostium. Now, at that point of time, the circumflex started looking bad, but I think that was basically because of the stiff metal in the LAD and the ramus, that the whole anatomy of the ostial circumflex changed. But we were a little concerned, so he decided to take a stent into the circumflex also. So we deployed the LAD stent first, took out the balloon, kept an ordinary balloon there, and now you can see two guiding catheters in the vessel, because we couldn't take three stents in the same time. So we have three stents here, one in the LAD, one in the circumflex, one in the ramus. Deployed each of them one after the other, and subsequently had an OCT run of the LAD, and as we had probably expected, there was a dissection in the distal left main. So decided to stent from the left main into the LAD, then recrossed into the ramus, recrossed into the circumflex, did sequential dilatations of the stents, and then we took an OCT shoot. Now, we took an OCT shoot, we can't see the stent in the left main. There's no stent in the left main, though we had deployed one there. So during all these manipulations, I think we realized that the stent got dislodged, and it was back into the, it was actually at the ostium of the left main, within the, a little bit into the guiding catheter. So luckily, we took another 5 millimeter stent there, deployed it, reshot the, took another OCT run, which showed that the stent was well deployed, and there was if you can see the ostium of the left main, you can see that there's a little overlap of the previous stent. So that sort of saved the day in terms of missing out on a stent in the left main. So this was the final shoot of the left main. And we had a 2-year follow-up on this gentleman. After that, we have lost follow-up on this person. So I'm not sure how he is doing. This is a short left main, again, a 74-year-old hypertensive, blackout episodes on walking for 2 to 3 minutes. Stress test positive. Angiogram showed 3-vessel disease. Treated the RCA in the first sitting. Second sitting, LAD, tubular LAD, tubular circumflex, did an OCT into both the vessels. There was a tubular lesion in both the LAD and the circumflex. What we realized was that there was some landing zone in the ostium, both the vessels. It was relatively clean. So went in and deployed the 2 stents in a V fashion, though not the best option, but we deployed both of them in a V fashion. And this was the OCT after that, where we had a good positioning of the stent, not impinging on the left main. Side branches were both the ostia of the circumflex and the LAD were clean, no struts across it, no major issues. And this was the final shoot of this patient. This was a lady who had a cardiac history when she was being taken for surgery, when she had a cardiac arrest just before being intubated, and subsequently brought out. She refused surgery. So this was the disease, an ostial circumflex. Did a rota first to the ostial circumflex. Then did an OCT. What the OCT showed was there was in spite of the rota, there was and a reasonably good cut on the rota. There was a calcific nodule at the ostium of the circumflex, and that sort of changed our strategy. We decided that we had decided we'll use a plain balloon, a high cutting balloon, and high pressure balloon and get out, but we changed it and we used a IVL balloon there, cracked it, and stented it. And then we stented the ostium of the LAD also. After doing all this and getting a very good result OCT-wise also, she came back in 6 months with a ostial restenosis of the circumflex. The LAD was fine, treated the ostial circumflex with a drug-coated balloon, and she's doing well. This is a 76-year-old lady, acute coronary syndrome, classical acute coronary syndrome, nothing much seen on the LAD. The circumflex had a lesion which was looking like a thrombus. So at that point of time, we decided we did nothing. We just kept the patient on Clexane, said we'll call her back in a week's time and repeat the angiogram. Repeated the angiogram at the end of 1 week, same shadow, then did an OCT. And this showed that there was a calcific nodule on the circumflex. It was not a there was no thrombus there. So at the same setting, we did a FFR to the, this is a calcific nodule. In the same sitting, we did an FFR to the LAD. FFR to the LAD was positive, so went ahead and treated the LAD with a rota and stented the LAD. Cutting rota, cutting balloon, and stent. Last case, this is also Dr. Matthews' patient. This was done in 2019. Elderly lady, acute coronary syndrome, 81 years old. Came in with severe angina. So treated the RCA, subsequently took her up for treatment of the LAD circumflex. Treated you can see the wire is quite out of the vessel. Treated the LAD circumflex, rota both to the LAD, cutting balloon to the LAD, treated the LAD circumflex. Patient came back in a year's time, recurrent angina, ostial LAD stenosed. We had already done a rota to the LAD just about a year ago. So we decided that in this we'll run an OCT. The OCT showed the stent was well deployed, but there was a significant amount of tissue in growth, and there was heavy calcium, significant calcium at the ostium, deep calcium. Now this is this thing. Now this is where the OCT, I think the OCT scores over an IVUS in terms of at least finding out the depth of calcium and the intensity of how deep is the what is the length of the calcium segment. So very often, when you do an IVUS, I don't know, Kirti he may beg to differ, but when you have significant calcium, you lose a lot of visualization of the interior of the vessel, especially with an IVUS. So that's one disadvantage that I see with an intravascular ultrasound. So here we decided that we'll go ahead and do a shock wave. We did undersize the vessel. We did undersize the balloon. We did not use a 3.5. We used a 3 millimeter shock wave. And after the shock wave, we can see an aneurysmal dilatation of the ostial LAD. And we did an OCT. And this was what the OCT showed. Now look at the ostium of the LAD. It's almost like there is no layer left. It's almost reaching reaching the adventitia. The last globe that you can see is there's no. It's quite scary. So I did ask Ziad what this is. So his explanation was that the calcium plate actually migrates out when you break it, and it makes it look like the whole thing is sort of expanded. Now I'm not sure what is the reason for this, but it was quite a. But ended up putting a stent there. Did an OCT again, which even a 4 millimeter stent would not sit there, so we used a 4.5, dilated it. And again, this lady is doing well because she came back with pneumonia about 6 months back with absolutely no coronary symptoms. Thank you.
I would have used IVUS because both of them were about to study the left main and the ostium of the where you put 3 stents. I would perhaps do In today's day, I would use one stent or two stents and use a DCB, a combination of DCB. And the second one, trying to nail with two stents, V stent, I mean, I would hesitate again trying to nail it, and many a times both the stents will come into the left vein and we can create a neo carina there. So again, I will use either a single stent strategy, or if I have to do two, I'll again do a decay crash. The third one is the eruptive nodule in the circumflex that you showed. It's a beautiful eruptive nodule, right? That was a nice eruptive nodule. So I would treat it like an acute coronary syndrome and will not use a debulking device there like you showed in your case. So these are some of the things.
The eruptive nodule was in the circumflex, left it alone.
Yeah.
Treated the LAD because the LAD FFR is positive.
Right. So, but that eruptive nodule was perhaps the reason for your ACS.
Possible.
So I would, I think you got a negative IFR there.
Yeah, and we had a follow-up on this lady also. She's regularly following up. She's good. I mean, so yeah, I think it's...
Right. And the last case that you showed, it qualifies under a content perforation actually.
Yeah.
So it's perforated and the adventitious is just holding it. So that's how it is.
Actually, I was doing a case last week, and it was a post-CABG, 1999 CABG. And the graft had closed, and there was a long tubular total occlusion of the OM, and that OM distally was filling up and filling up the RCA also. So we opened up the OM, and a cutting balloon also at 14 atmospheres didn't open the lesion very well. So I thought I'll now use an IVL there and open it because there was some calcium seen there. But very subtly, which we didn't notice it, I found just a little dark staining on the wall of the vessel. And if you would have missed it otherwise. If I'd taken an IVL there, I would have caused a full-blown perforation. And it was just a small discoloration of the wall. It wasn't even, and no perforation seen on the angio. Just a discoloration of the wall of this thing. Again, coming to your the questions on trying to nail this thing. I mean, that was Dr. Matthews' this thing. He was a fan of doing it that way. The number of V stents that he's done, and this thing. In fact, I had just recently, just 2 weeks ago, did an angiogram on a lady he had done just a year and a half ago, when he was actually in between dialysis, in between chemotherapy, everything. And he used to come and do cases. And this was a tough case, osteal LAD, osteal circumflex, ramus ostium. And he did the circumflex and the ramus osteal, first stage. Called her back, 1 month, did the LAD ostium, bang osteal. She came back with angina. I thought something has restenozed. Nothing. As clean as a whistle. Right had progressed. So somehow I think it's, you can't.
Okay. Thank you so much, Dr.
Thank you.
Acharya.
Thanks.
I think we'll go to the next presentation because we are running out of time. Nagesh, if you can come.
Good morning. Thank you, Kane sir and CSI for this wonderful opportunity in this August gathering. Okay, so I have a couple of cases. We'll go step by step. So imaging has changed the way we are doing angioplasty, as Matthew sir already told, that it is helping us, and we are getting dependent on that also. And between IVUS and OCT, I think for majority of the people, the way the detailed imaging happens on OCT helps us take decisions easily. IVUS needs long learning curve. There are many images where we are not able to interpret correctly. So again, challenges in treating severely calcified lesions, we already know. If we don't know what it is, we end up with under-expansion, malapposition, and complications in future. We need to assess the calcium properly, and there are scores now available while assessing the lesion. Then we have to assess the post-lesion preparation, whether the calcium is modified, the luminal gain is there, and debulking is happening, and finally the post-stenting also. And this is how the calcium will be: concentric, eccentric, and nodular. Then we look at the severity in the score. So ultimately, if the score is very high, it will end up with the under expansion if we don't treat and prepare the lesion properly. This is how the calcium modification is seen after we take proper steps. So going to this case, so this is a young lady, 47 years old, who presented with NSTEMI, aggravated rest angina with enzymes positive, and she is found to be diabetic also with glyco-HB of 6.6. It was a discrete lesion at the LED diagonal bifurcation. So there was no much calcium seen on the angiographic, but it was a LED and I did not want to mess up, so I wanted to use imaging. And looking at the bifurcation, we can see the vessels were running parallelly, but the origin looked as if it is at 90 degree from the LED. So I was not sure whether the diagonal is going to get compromised or no. So imaging, again I decided to depend on to take a decision about how to go about the bifurcation treatment. And I wanted to protect the diagonal, so that was my strategy. And ultimately, one stent in the LED, and if required, a drug-coated balloon or a provisional stent in the diagonal was my initial thought process. 7F guide catheter was used, and the first OCT run showed that it is a discrete predominantly fibro fatty lesion at the LED. We can see here as we are progressing toward the lesion. This is the lesion site. We can see the negative remodeling and significant fibrotic plaque there. Here I failed to appreciate significant calcium. So the plaque is predominantly fibro and lot of lipid core within the fat. Calcium was not visualized, and we can see a diagonal which is seen here, and the angle was narrow. So this is how, so the diagonal also was narrowed. So the plaque was hanging in a way that it was coming in the way of, or at the branch point of the LED diagonal bifurcation. So then I wired both, prepared the lesion with 3 NC and followed by 3.5 NC, and I did some kissing balloon dilatation also to keep the carina in a better way and modify the plaque which was hanging towards the side of the branch point so that it is not getting compromised. So I took all the necessary steps which I thought will prevent occlusion of the diagonal before I put a stent. So after preparation I did the OCT. So here came the surprise. We can see eruptive nodules which are now visualized after the lesion was prepared. Now I was left with eruptive nodules which were not initially seen. So how to manage this? And again, diagonal was important vessel. I did not want to lose it. And imaging confirmed it is at risk because the CT angle was narrow and the BPCT length was narrow and the plaque was hanging in a way that it may occlude the diagonal once we compress with a stent. So I prepared that lesion further with a cutting balloon 2.75 by 10 Wolverine. So I planned to treat D1 by DCB versus provisional stent, and many issues were there at the bifurcation, narrow angle, overhanging plaques and the diameter mismatch. So which strategy to be used if we do bifurcation? So there were issues with that. So looking at the eruptive plaques, eruptive nodules, it would have been a great help to use orbital atherectomy in this case, but I was not prepared. It was not available in-house, and I did not anticipate as the angiography did not show significant calcium there. So I was assuming the eruptive nodules were predominantly fibrotic with some calcium, and they were sitting in the lipid rich plaque base. So probably I will get, so that was my calculated risk in this case, and I still went ahead with the stent deployment in this case. So 4 by 18 Zion Sierra was deployed in the LED. Away from the ostium, I had a landing zone there, and after I removed my stent balloon and took a check shoot, I saw the diagonal is gone. I am not able to see any flow in the diagonal, so this was a mess. We have to salvage the diagonal. There was TIMI zero flow here, and a very narrow angle. I was not sure whether I will be able to take a wire directly without having some trickle of flow in the diagonal. So what I did was I took 1.5 millimeter balloon. I tried to take on the wire which was abluminal in the diagonal and created some passage for that. So this is how I took initially 1.5 balloon, and then before I inflate the balloon on the abluminal wire, I wanted to protect the stent in the LED. So I took a 4 millimeter NC balloon and kept it distal to the diagonal origin in the LED, so that any deformity happening because of my endeavors with the diagonal wire will not cause me re-entry into the LED stent across the diagonal branch. So I kept that 4 millimeter NC in the LED distal to the origin of the diagonal, and then I used 1.5 millimeter balloon, created some channel there. So some flow was seen here. Now at this stage, I took another wire, entered the diagonal through the stent struts which were in the LED, and I could go in successfully, which I confirmed with the OCT which I had on table. So after that I removed the abluminal wire and the balloon, and then I did the kissing balloon dilatation of the LED diagonal with 4 millimeter NC in the LED and 2.5 in the diagonal. After successful kissing balloon dilatation, I saw a good flow in the diagonal. It was TIMI3 flow, but there was something hazy in the proximal segment of the diagonal. What was it? I don't know. Maybe a thrombus which is formed there because it took time for me to intervene, or a plaque which is shifted significantly into the diagonal, or something else. And if we know this exactly, we'll be able to take the next step precisely. If it is a thrombus, we can manage with anticoagulation, better antiplatelet, and we can avoid a stent. But imaging was must to take the decision, because I had a plan of using drug-coated balloon also in this as a option. So I did do the OCT for the diagonal to LED, and I saw there was a nasty dissection with intramural hematoma. We can see this. This is the large intramural hematoma seen in the diagonal proximal segment. So when this is there, it has to be treated, and drug-coated balloon as an option is out in this scenario, as per my opinion. So I had to use a stent here. Now I left with a only strategy is to do a tap, and tap that too in a very narrow bifurcation angle. So it was a challenging case. So, but ultimately there was a 4 millimeter balloon, NC balloon in the distal part. I used it as an anchor to stabilize my guide catheter and the wire, and I used the stent 2.5 millimeter by 15 Zeiss, and I deployed it in a way that with minimum struts in the hanging in the LED, and then I optimized it further and did the OCT. So distal edge was good. So when we look at the OCT post optimization of the stent, we have to look at the max algorithm. Then the positions was good, the expansion was good, there were no edge dissections, and there was no tissue protrusion also. And the point of the polygon of confluence at the LED diagonal was also good. So there were no major struts hanging in the LED coming out from the diagonal. So OCT has helped me significantly in this case to look at the stent, the way the carina is formed. And we can see the POC was good, the expansion was good, and we can see the 3D stent rendering and the entry of the so the opening of the struts across diagonal and the stent positioning was optimal, and this was the eruptive nodule which was seen after the first pre-dilatation of the LED lesion, and now I got a good expansion with good opposition in the segment of that LED where the eruptive nodules were. And this is how the fly-through view will be 3D, and I could see the stent struts which were sitting properly, not protruding into the LED, neither in the diagonal. So both the openings were good, and so there was some metal at the carina, but I'm happy with the outcome and the way it is seen in the OCT gives us comfort. So this patient is doing good, and I'm keeping a close follow-up. So
Nagesh, I think we don't have time for the second case. So if we can have discussion on this.
Yeah.
Yeah.
Very nice case. So I wanted to, this was always there in my mind, when you have a critical lesion like this, doing OCT without a small pre-dilatation can become a problem because the dye doesn't get washed out, and that's perhaps the reason that we missed the eruptive nodule in the first run. So my question is to Ronnie, in such a critical lesion, without doing a pre-dilatation, how do you do an OCT? I mean, sometimes the dye is just staying there. So that I want to hear from you. And is that the reason that we missed the eruptive nodule in the first pullback?
Yeah, no, see, there are advantages and disadvantages of both. If you have a tight lesion and the dye doesn't go, you can still do an OCT by injecting through the side port distally and then do a manual pullback. Through the side port, send the contrast inside so that it puts the contrast distally, and then inject forwardly and pull back. You'll get a good picture.
How do you inject from the side port? It's very hard, right?
It's hard from the flushing port because you got contrast in that. It's a good technique. It's a very good technique.
Can you tell us step by step what do you do?
Okay, what you do is you put the machine on manual. Okay, you put it on manual mode, and then you get somebody to inject through the side port. Contrast to the side port is very hard. It's a 1 millimeter syringe, no?
Yeah.
So with a 1 millimeter syringe, you push it in. When you push it in, because this catheter is blocking the distal flow, contrast fills up distally, and then you inject with your hand proximally and do a pullback. It's a very good. But having said that, I think you should be careful because you can get a ventricular tachycardia because we have contrast hanging inside that. So you should be very quick to pull it out and pull the catheter up. It tells you the morphology very well when you do this. But again, it's always good to get a frank morphology because I don't know, I have to see this properly on the workstation. But to me, I don't think that is eruptive calcific nodule. I think what has happened is it's a fibrotic with a lot of lipid, and once you dilate it very well, you get a lot of dissection, you get thrombus forming on that. It looks like a calcific nodule, but to me it doesn't appear like a calcific nodule. No, but but I allow to see it on the workstation to tell you correctly. That is not a calcific nodule. That is what a good fibrotic plaque, fibro-fatty plaque will look after a good balloon dilatation. And then, yeah, somebody was talking about the eyebrow sign. I think in this, if you see that OCT, can more or less tell you the angle of that side branch is such that if you put a stent into your main vessel, you will get an occlusion of the side branch. You can preempt it because this is where the side branch is. If you rotate this, you will find that that this is coming over here, and then this starts like this. So the moment you implant a stent here, that goes up there and it will occlude this. This will go up here and this will occlude the side branch.
So what's the angle that you?
No, this is not the correct. This is not the correct view for that. You rotate this in such a way that you see this part coming right up till here. So you can just imagine in your mind if this is still here, and you expand the stent to this size, this is going to hang here. And that's the eyebrow sign. So this is the eyebrow. Then not this. If it comes till here, that's the eyebrow. So this is going to, and then there's so much of plaque, this plaque is going to go there. So this is going to be a combination of your eyebrow sign shift and also plaque shift, both of which will cause very tough case. I entirely agree with you. Dealing with this case is a nightmare, especially because the diagonal is at narrow angle coming right near the left main.
So
this
Ronnie,
is the diagonal, sir.
So when you
BTCT angle, yeah.
When you want to see that angle, the essential thing would be to align the axis through the side arm, right? The axis doesn't necessarily go through the side arm most of the time. So you need to reorient your axis, and then you'll see the carina or the eyebrow, right?
Yeah, because you must remember the bifurcation according to your strategy, the fractal law. This is this big, 4 millimeters. This has to be 3.5 or 3 because this is going to be 2. So when you get this 3 to also this size, because you're doing a balloon across, and that's going to push this ostium this eyebrow even towards the ostium and shut it off.
On the same image that you're talking about, which he thought was eruptive nodule, my impression was that it's a very lipid-rich plaque.
Yeah.
And when I see something like this, I almost start thinking of slow flow when I'm going to dilate initially.
No, I agree, because it didn't look like a. It didn't look like a lipid-rich, like a eruptive nodule. It's very likely that it's an acute, thrombus forming over there. And very often we are biased in our minds that when we see these lesions, that these are eruptive, because that's been drilled in. So I think a lot of times these, and we see it even post-stent sometimes.
You mean to say this is red thrombus?
Yes, that is red thrombus sitting over lipid.
And when that happens, and you already have all the possibilities of the side branch closing, if you have a thrombus there, you need to change. Probably we need to change our strategy and think of a 2-stent strategy to begin with, because we know that lesion is going to close. So the thrombus migrates there.
So which 2-stent strategy you will use, sir, in this case, if you do this case? Elective 2-stent. You will use a decay crush or a mini crush, either of the two.
Either a decay or a mini crush. Okay. Again, the problem with any of these is you're not going to have space for a pot or anything. You'll have to just dilate with both the lesions and get out.
One question, Ajit and Ronnie, how do you differentiate a red thrombus versus a nodule on OCT,
Yeah,
It's very difficult, many times.
That's a big question. So you must understand. The eruptive calcific nodule, light doesn't pass through the margin because there is thrombus on the eruptive nodule. All right? That is one of the reasons why we call it an eruptive nodule. And an eruptive nodule is basically calcium that is fragmented, that has come out through your intima into the lumen with thrombus sitting over there. You can never get this erupted like this once you put in a balloon. The moment you put a balloon onto the eruption goes onto the side. Causes slow flow.
No, but how do you differentiate a red thrombus from this nodule? Suppose it is not eruptive, it is just non-eruptive nodule.
Precisely. You will not know that because there is thrombus sitting on the eruptive nodule. When you do a de novo run, see, also remember, the nodule keeps the company. If you see an eruptive nodule, you have to see calcium proximally and distally. So never make a diagnosis on OCT on a single picture. Push it up and down, you will see calcium there, it's eruptive nodule.
That is what will differentiate. That is what.
Seeing calcium in the neighborhood is
unlikely to be a nodule.
Just go back on the previous image. Just go back.
It's lipid-rich plaque.
Yeah.
Lipid-rich plaque.
So adjacent you should see calcifications.
Go back a little, another one.
Because it always keeps the company, that's remember.
This.
Pre-stage. The first one after the.
You see right here, this longitudinal view is clearly representative of a very lipid-rich plaque.
Yes.
I mean, you don't have to look at cross
If you
section.
see these areas,
Yeah.
they're very classically.
It's not calcium.
There's no calcium anywhere on either side. There's more likely to be a.
Yes.
Nagesh, you made a statement that if you had an orbital, you would have done an orbital in this. I mean, even if it is, you assume that it's a eruptive nodule. I don't think there is a role of orbital in eruptive
No,
nodule.
in fact, any ablative technology in this would be a serious slow flow because this is a lipid-rich plaque. And even see the balloon dilatation, we get slow flows. Yeah,
No, suppose this.
Yeah. Thrombus.
Can Ronnie, Ajit here, one comment. I will elaborate on what Ganesh said, that if you have a very critical lesion in one of the major arteries, I think doing an imaging is fraught with problems. Because you can get a slow flow. I had a patient who had an arrest and the patient had to be brought out. So what he says is dilating a little bit, maybe a 2 millimeter, and then going ahead with the imaging catheter is far much safer than this thing, no question. But we still get all the information, yes.
So, Ronnie,
I think this was an excellent case. We had a lot of discussion, but we need to move ahead because we are very, very late now.
and why should
Thank you, Nagesh, for the.
Same no, tight lesion, pre-dilate and dilatation.
Good afternoon, friends. I think we were having a discussion on whom to use OCT, whom to use IVUS. I think everybody forgot about CKD. So if we are dealing with a patient of CKD, I think IVUS scores over OCT, except maybe in RCA. In RCA, you can get good saline OCT pictures. I'm going to present a simpler case. This is not presented, so I thought I'll present it. The 55-year-old male with hypertension and diabetes with moderate LV function presented with unstable angina. With a prior history of PTCA to RCA almost 1.5 years ago, and a clear-cut history of DAPT non-compliance. So this was his angiogram. You can see the RCA. RCA has become streak-like, but there's a lot of retrograde collaterals from the left system. You can see 2 overlapping stents over here. We didn't get the details of the stent. The patient came in emergency. Now with this sort of a picture, obviously I went ahead with the angioplasty with an imaging, especially when you are dealing with a stent failure within 2 years of implantation. So I, with this kind of lesion, always predilate because you are not going to get good images with OCT. So cross with a Sion blue wire, dilate it with a 2.4 NC balloon throughout. And you can see this picture. You can now feel that now if I put the imaging catheter, I'll get the right pictures. Important thing to know here is what is the actual sizing of the artery, why did the stent fail. So these are the OCT pictures. Sorry. Will it run? This is not running, dear. It's running. So OCT revealed a significant neointerminal proliferation as well as neoatherosclerosis and an undersized stent most likely. Because if you see my expected stent diameter is coming to be almost 4.1 in the proximal segment and almost 3.9 distally. You can also see areas of plaque rupture and some dissections. So very bright areas are telling you that there's a lot of new atherosclerosis as well. So I took a 3.5 Wolverine and dilated it at high pressures. And following that, I deployed a 3.538 stent in the mid-RCA and a 4038 overlapped across ostial mid-RCA. And then again post-dilated distally with 3.75 and proximally with a 4 balloon. This is the post-OCT run, post-implantation OCT run. There was some under-expansion which I corrected again with a 4 balloon. Now you can see that the stent is well deployed, well apposed. And good MLAs and MLD max. And this is my final result. So you can see a streaky artery, looked quite well grown. So probably the stent was undersized. So in cases of ISR, I think imaging should be considered in all cases of ISR. OCT has an advantage of giving an underlying pathology of ISRs, mechanical versus a biological factor versus mixed. In our case, it was probably mixed. He omitted drugs as well as the stents were undersized, and it helps you to choose the exact modality of treatment and improve the outcomes. So this was a ISR case. Now my second case is an elderly 78-year-old female. With, as coronary interventions are advancing, although our acute MI patients are becoming younger, we are also faced with patients which are 70 plus, 80 plus. This is a story of a 78-year-old female who came to us with a CD of double vessel disease, but with a prior history of surgical closure of ISD. Looking at the calcium, she was advised bypass surgery. The relatives did not want a bypass surgery simply because she had already undergone a surgery. So this is her RCA. You can see a tram track-like calcification in the RCA and a very tight lesion. And this is her LAD. So again, I planned this case because the patient was elderly, patient had two vessel disease along with a lot of calcium seen, so planned the case with a OCT. I also kept a IVL ready because she was elderly. I didn't want to fail at the table just using a cutting balloon. So right coronary was engaged and pre-dilated with a 2x10 NC balloon. Most of the time I do dilate very tight lesions with a 2O balloon gently, because then it is easier to do imaging rather than just doing it directly. So with the PCI distal EEL diameter was coming around 4 and proximal was coming around 4, and you can see the pictures. This is the OCT, you can see the pre-pictures. The calcium is deep actually at the lesion site. You can see a deeper calcium at this lesion, and the lesion is fairly tight. So used a 4O IVL and used around 50 pulses, and then this was followed by a 4O stent, and this is the post PCI run. So well opposed, no edge dissection, good MLA, good MLD max. Now I had around 30 pulses left. The LAD lesion I thought may require some pulses as well, and maybe I would add a cutting balloon if needed. So this is the RCA post PCI. Now this is the pre-PCI run of the LAD. Lesion did show some deep calcification, but it was not very tight. Not very significant enough to require any great plaque modification. I had these remaining 30 pulses which I used along with the cutting balloon and then deployed a stent. You can see that the results are good even in this. Post dilated with a 4O, and this is the result of the LAD. So friends, this is just a few cases that we use. I think the imaging, I practice in an area where patients are not very rich, but still we use very high volume of imaging, purely because I want to learn. And now government has sanctioned OCT and imaging in CGHS patients. So post-COVID, we have been using in practically most of the patients of CGHS, and of course, those who can afford in them. So this is how I improved my learning curve by using it in CGHS patient. Of course, the company people will not like it, but we do reuse OCT catheters. That's how we improve learning and improve volume. We have been reusing balloons, so we tried reusing OCT catheters also. And I think it improved the outcomes and it has improved my learning of imaging. So current penetration of OCT imaging in our center, which is a small center, is up to the tune of 25%, which is fairly good. So I would suggest Dr. Rawat, I think, don't worry about the money. I think we should learn and use it in our CGHS patients because it is now approved. Thank you.
Thank you for the good case. I think Amit has a question.
One question, sir, with all of you using OCT, especially the forum. We see all these young patients with ACS, and you're coming to us, and we see some minimal thrombus. By the time they reach us, they've already been pre-treated, and you get a very clean artery on angiogram. Only to, some minimal haziness you see. I'm talking of the proximal segments, LAD, LCX, or RCA. You see in the proximal areas. And you feel that we'll be giving him GP2B3A 24 hours and then reassess him with the OCT. That's what we do usually. And then we find out that, of course, it's a plaque erosion, but there's some white thrombus there at the proximal segment, of the LAD or the circumflex. In that case, sir, even if the MLAs are good, would you still go ahead and treat this as this thing, or would you leave this? Or do you decide as per the thrombus load that should we stent this or leave it?
No, I think, plaque morphology in ACs is entirely different. Now you've got three plaque morphologies there, rupture, erosion, and a nodule. So if you have a rupture, the conventional thing is to go and stent it. If there is a rupture anywhere that you see, because there is no data to tell us right now that you can leave a rupture. Though I think in erosion 2, which was done in China, they left ruptures if they had a decent MLA and good TIMI3 flow. And in those patients, they found the results were good. But that is not a randomized trial. So we have no randomized trial as far as ruptures are concerned. Now you come to erosion. In erosion, we have got enough data from the erosion trials that tells us that again, if you got predominantly, and in erosion, if you come after 2 days, you will see white thrombus. So you see white thrombus, you can leave it if your MLAs are good, TIMI3 flows are good, and they run a follow-up up to 3 years, the results are good. So again, plaque morphology will dictate your PCI approach in ACS, depending on what you see.
Just wanted to share that you need to be very cautious on patients who were thrombolized and came to you. So in our experience, what I have seen is that you see a lesion which is very tight in the mid LAD, but you will find a very big plaque rupture in the proximal LAD if you image them. So you're going to miss a proximal LAD plaque rupture by just stenting mid LAD. So that has also improved our learning especially in patients who are thrombolized. So be very careful of thrombolized patients.
Ronnie, I have one question. Plaque erosion. Now when we do an OCT in an acute MI, you see thrombus everywhere. So how do you identify plaque erosion? How easy is it to identify plaque erosion?
No, that's a very important question. See, in the erosion, to make a diagnosis of erosion, you have to thrombus aspirate your entire thrombus. Because in an acute MI, you have red thrombus sitting, and you cannot see anything behind the red thrombus.
Absolutely,
so you may have a nice rupture with a thrombus there. But the point is that now, in case you do see good lumen, and you see some red thrombus, you may leave it, so you come back the next day and recheck it, because you can avoid a stent if there's an
Absolutely,
erosion.
because it's not, we have found that it's extremely difficult to diagnose erosion in an acute setting. So many times they say you many days they say you should do an OCT later on, but you take decisions acutely, no? You can't wait for a few days to see that the thrombus is gone and then come back and see that it is an erosion. So if you're planning for a delayed stenting, you may be able to do that. Otherwise, it's difficult. And,
Yeah. So I think, Jia, the way I would look at it is, if you look at Ajit Molasari's data from his data, and if you look at the way it has panned out, if you do an angiogram in a patient who's had an acute coronary syndrome and you feel that the angiographic lumen is good and there's a haziness, and you do an OCT and the MLA is good, the residual MLA is good, and there's a thrombus per se, I think these people young people can be left alone on anticoagulation, and when you bring them down 6 weeks later, you realize that a lot of it is cleared up. And so I think that
it does. We have done that so many times, but you find that there's nothing. Artery has become almost normal.
Absolutely, and therefore it would be not very great to...
So if the thrombus is non-occlusive, you can always wait.
You can wait, yeah.
But if it's a total occlusion, then you have to treat.
Can I just one question? The first case, Roni and you also, Kirti, she had a long instant wrist stenosis and treated again with a stent, just to learn around from other people also. It was well expanded on imaging. Do you expand it into the drug-eluting balloon and leave it alone, or you have to put such a long stent along? Because too long stent like this will create a wrist stenosis to the extent of 20-30%, I believe. So in spite of doing with the imaging, there is some inherent risk of stenting like this. So since it was unexpanded, dilate to the, because imaging was a dilate to the velar position, and so drug-eluting things, which is a better alternative?
It's a very difficult question to answer because we don't have data to show which one's better, but anecdotally, and correct me if I'm wrong, in the ISR, in the ISR segment, you see two distinct anatomies. You see the late stent thrombosis or the early ISR, which is on the left side, and then you see the chronic ISRs, which come on the right side. On the left side, you'll see more thrombus, and you'll see soft plaques. On the right side, you'll see very fibrotic calcified plaques, which are resistive to... She probably had the left side, which came in either late stent thrombosis or an early ISR. And these are the patients who will come at 12 months, 14 months, 15 months before that. And typically on the right side of the curve, you'll see people who come back 3 years later where there's peri-stent or in stent. Within the stent, there is calcium. That only happens at 3 years. Now, when you look at the left side, there's a problem that when we looked at our own data, in fact, we're sending all our CDs to MMM for evaluation. We found that in the soft plaque, when we use conventional technology, we see distal embolization and slow flows when we treat those. And on the right side, we realize that we may do whatever you want and they don't expand with whatever technology. We've used rotoblators in the past, we've used cutting balloons, we've used IVLs, OPNs, everything. What we're doing now is on the left side, on the softer lesions, when you use excimer laser, we find that the plaque ablates and then you do a contrast run. You do an excimer laser with contrast. And what we are looking at eventually to decide whether we are going to get away without drug-eluting balloon alone or we need to put in another stent is the volume of tissue that remains inside the stent, which is free floating. And what I saw in your OCT was floating tissue. And these will typically come back and they'll occlude these arteries and they'll kind of reform. So by using excimer laser, we are able to clear up that in-stent tissue, and we can take all that tissue and put it out and you get a clear lumen. Wish I could show you some stuff, but if we can get that with a good expansion, then drug-eluting balloons do brilliantly. Sorry.
So,
Dr. Shantanu, last
just-
question. Okay, you can comment. Yeah.
the stent, we have to basically understand the reason for the stent failure. In her case, the stent failure was because the previous implanter had implanted a smaller stent. In a 4 mm vessel, underexpanded. Okay, so smaller diameter stent. In these type of cases, you need to expand the stent and perhaps put another stent inside. A drug-eluting balloon is not going to help with such a long thing. Another condition where a drug-eluting balloon is not going to help is a late restenosis where there is a neoatherosclerosis, which you will have to treat it as a native lesion inside a stent. The place where I would use a DCB is where the previous stent is well expanded and then there is a restenosis, I would just cut it and put a. That is where I am going to use a cutting balloon in a fairly well expanded stent previously and a tough tissue inside. But in cases like hers, where it was an under expanded stent, I would not use a cutting balloon. I mean, cutting balloon is not going to expand my stent. I would use a high pressure balloon and open the stent first. So many of us by default, when we see a restenosis inside a stent, we ask for a cutting balloon. I mean, cutting balloon is not a treatment for an under expanded stent.
Okay, yeah, that's the last comment and then we go ahead. Yeah. Yeah.
DES, because the pattern also on OCT is different. Heterogeneous pattern versus homogeneous pattern.
Shantanu, yeah, that has always perplexed me. Where is BMS? We don't even see a single BMS available in our country. So how they are doing a trial on BMS? Are they still using BMS?
That was an initial period when the
yeah, I know, yeah. But nowadays it is, I think, superfluous to talk about BMS because nobody uses it. Yeah, anymore.
But restenosis rates are still lower with a restenting of a drug-eluting stent than a drug-eluting
we'll go ahead because we are exceeded our time. And thank you very much, everybody, all the presenters and Dr. Ronnie Matthew for this excellent session and all the chairperson and moderators. So we move on to the next session, which will also include imaging because obviously calcium modification cannot be done without imaging. And to present it, we have a guest speaker, Dr. Girish Navasundi from Bangalore, who has a very, very large experience in doing imaging as well as doing all sorts of calcium modification techniques. So we also have a lot of good operators and experienced people here, so we will learn from each other. And I invite Dr. Navasundi to make a presentation and Dr. Amit to call for the moderators. And
so I would request Dr. Kirti Puname sir is right here. Dr. Anand Rao, he's come out. Dr. Ajit Desai sir, please if you can come up. And Dr. Vitisha is not there. Okay. Rajiv Sharma, Anup. I guess you guys at least can come ahead because you guys are like somewhere in the end of you're like last benchers. Come ahead at least. Yeah. And Dheeraj, if he is there. Dheeraj, I think just left. So come, Rajiv. Come on. Thank you. Sir, please talk.
Thank you. Thank you, Dr. Kani and beautiful CSI Mumbai team, very learned and luminaries and deep thinkers. I'll, put my 2 pennies of thoughts on device strategy for calcium management. Why is it important to understand calcium? Prevalence of calcium, when you look at it, look at people less than 40 years, 40 to 50, 50 to 60, 60 to 70. As the age progresses, percentage with coronary calcium of more than 0, when you look at this, between 50 and 60, about 66% of them, men have calcium. When you look at 60 to 70, about 83%. Even those between 40 to 50, 44% have calcium. And those who have these risk factors, there's a higher probability of having calcium. And again, very important to understand how does it happen. Look at that pathognomonic mechanism of calcium. Initially, you have macrophages, then there is a small pool of extracellular lipid, then extracellular lipid becomes a core, and then there is this cap that develops initially fibrotic, but that's where the calcium starts depositing towards the cap. It could either be inside or towards the outside when you call it superficial or deep. Again, you call them in different words, no plaque, soft plaque regression, then non-calcified, then mixed plaque where you have fibrotic as well as lipid, and then you have calcified plaques. Why is it important? When you look at them, there's an increased cardiac mortality risk as there is increased calcium. Look at that. If it's from 0 to 100, there's a significant increase, and more than 100, much more increase in the MACE events, including mortality. Now we know both the imaging is very, very crucial. You have multimodalities today to look at calcium. Matthew sir beautifully showed you one of them, that is the OCT, but Most of the time we start off with CT angiography, coronary angiography, then intravascular, either IVUS or OCT. These are the four modalities that we use. What do we understand? One of the simplest is on CTs, most of them these days, patients themselves get it and come and show it to you. These numbers are important. Look at calcium score 0, 0 to 100, 100 to 400, and more than 400. What happens? Unadjusted annualized rate of cardiac death and non-fatal myocardial infarction, when you look at it, if 0, 0.65%, 1.4, almost it's more than doubles. If it is between 100 to 400, it becomes 4 times. And if calcium score more than 500, this is almost 10 times or the event rate. So calcium should not be taken lightly. So this is very, very important. Rates of MACE, MI, stroke and all-cause mortality, very important. Look at this bars. When the calcium goes up more than 100, this almost becomes 3 times whatever you're looking at. So stroke increases, MI increases. It only means more advanced atherosclerotic chronic inflammatory disease, which leads to more vulnerability. Again, the same thing when you look at the death, MI, TVR, when you look at them with the P values of this, almost 60% increase that happens in all these events when the calcium goes on increasing. And now, how do you look at calcium? Which, as an interventional cardiologist, this is what we have. CT has become a tool, but in the cath lab, when we look at it, what we have is an angiography, IVUS, OCT. When you look at the lesion with high calcium content, angiography can also show you if, as a time track. You can see 2 lines. If it's severe, IVUS can show it, OCT can show it. That's no problem. But when it's mild to moderate, angiography is poor, IVUS is better, but OCT is excellent. When you look at the deeper calcium, I think angiography is not good enough. IVUS is the best, but the OCT actually tells you the depth much better. When you look at the calcium arc, angiography is not good because it only gives biplane. Here you get 360 degree in these two. Calcium thickness is very difficult to calculate in angiography and IVUS, but it's the OCT. And longitudinal, the length of the calcium in the vessel segment, again the best is OCT. Only reason we were discussing, erupted nodule. When you have multiple characteristics, calcium, thrombus, fat, I think that's where IVUS gives you a little advantage over OCT. But otherwise, OCT is the most ideal tool for calcium visualization. How's the calcium distribution? When you look at the intima, media, and adventitia, it could be superficial, or it could be nodular, or it could be deeper. That means more towards the media and adventitia than media and intima. That's how you call it, either superficial or deep calcium. And again, you just for understanding young people, you need to look at eccentricity, whether it is eccentric calcium, concentric calcium more than 270, or it's a calcium ring when it becomes 360 degrees. When you look at the depth, distance from the lumen profile, how deep is this? This depth is very, very important, whether it's a nodule, eruptive or non-eruptive. Then do you have a superficial calcium or a deep calcium? But what is the distance from the lumen? Also important to calculate the thickness, because ability to break this and increase the compliance of the vessel depends on the thickness as well and circumference. And then length is also very crucial, because if it increases more than 5 millimeter, the event rates are higher and you need better tools to deal with them. And again, severity of calcium, you must use imaging. Just looking at an angiogram and having, it's not an excuse, just to have a cath lab without investing into an imaging and wanting to do type C or a complex lesion, I think is not a fair medical practice. Today, an investment into an imaging tool has to be part of the setup of a cath lab, wherever government or non-government. I think we need to look if we desire to do complex cases. Looking at the severity, you have IVUS-based calcium scores, all of you know. The same 4 things would be measured. What is the length of the calcium, more than 5 millimeter, or the arc 270 degree, presence of full circumferential 360 degree, you get 1 point. Then vessel diameter less than 3.5 millimeters, you get 1 point, and nodule gets 1 point. Any calcium score of 0 to 1 is called mild to moderate. 2 or more on IVUS, depending on these 4 parameters, if the score is 2 or more, it's called severe calcified lesion. On the contrary, when you have OCT-based calcium, the arc, instead of 270, it becomes more than 180 degrees, and you get 2 points for that. And an arc of 90 to 180 degree gives you 1 point. Calcium length more than 5 millimeter, 1 point. Calcium thickness. What is the thickness of the calcium? If that is more than 0.5 millimeter, you get 1 point. Here, up to 3 point is considered as mild to moderate. 4 or more among them is considered severe calcium, which helps you to strategize your calcium modification tools. For example, case 1, here when you look at the calcium, it appears dark. You have a more than 270 degree, not really. So 360 degrees, you are seeing all across. They say it's 1 point. There is no nodule anywhere, and vessel diameter is actually 4.4, not less than 3.5. So you only get 1 point. So it's a mild calcified lesion. And when you do an angioplasty, you get a great result. And now look at the second case, more than 270 degree, the calcium, it's come to here. Then you have calcified nodule. You can see here there's a calcified nodule. And then vessel diameter is 2.9, so it's less than 3.5. When they implanted the stent, you haven't got, stent expansion is only 55% compared to 98%. So it's very important to understand calcium from the imaging perspective, not from the angiographic perspective that we are all used to. Now, how do you treat a calcium? The purpose of doing an angioplasty is to get the largest lumen available for the blood to flow without having major dissections or having non-uniform expansions. That's very, very important. So there are balloon-based strategies and ablation-based strategies. So balloon-based, we all discussed so far, I think beautiful discussions. Non-compliant balloons, which are the minimum that we start with at 18, 20, 24 atmospheres. Then you have high-pressure dual-layer balloons, which are totally non-compliant, which can go up to 35 to 42 atmospheres. Then you have cutting balloons, either with atherotomes or with nitinol wires, or sometime even PTFE shoulders. Then you have scoring balloons, then intravascular lithotripsy. I think it's a very, very popular tool which sends waves of ultrasonic waves which cause breakdown in the integrity of hard substances like calcium. So converts a ring of solid unit of calcium into multiple smaller pieces so they can be expanded. The compliance can be changed. And then you have atherectomy tools. Atherectomy means you cut that or convert that hard substance into finer powder, where you increase the lumen area prior to your, rather what we call debulking. Not only atherectomy, you also debulking, taking out some of the tissue that does not have to stay in the vessel wall. You have rotational atherectomy, orbital atherectomy, and laser atherectomy. I think I'll leave it to Dr. Kirti to speak on laser because we have not had laser. Looking at what is important is balloon compliance. When you choose a balloon, if you want to just feel how severe is that calcium, this is how dog boning will happen when you inflate. Balloon compliance, what do you mean by that? The change in balloon diameter per atmosphere of inflation, stretchability of balloon, approximately 0.095 millimeter per atmosphere for a semi-compliant balloon and 0.01 millimeter atmosphere for non-compliant. When you use in a calcified lesion, always use non-compliant. Otherwise, what happens? If you use a semi-compliant, beyond the calcified segment, it will overexpand and cause significant dissections and hematomas. Now, semi-compliant balloons expand in diameter as the atmosphere increases, may result in dog bone, as I said. And in the non-compliant, you have a consistent diameter throughout. It will be like this. That's what you wanted. You can see as the compliancy decreases, the diameter change becomes less and less. That means if you use a 2.5, maximum even at 30 atmosphere, it may go to 2.67. If you use a compliant balloon, 2.5 at 20 atmosphere, it may become 3.2. Right. Then you have just to look at it, this is the circumference height. This is the IVL balloon, what you're saying, single layers. How much atmosphere of pressure you are able to transmit to this constricting band of tissue. It could be pure calcium, fibrocalcific, but your eventual goal is to achieve this. Make this shoulder and the stenotic segment of almost equal diameter without causing too much injury to the healthy vessels. So when you look at with the high pressures between 20-24, you can achieve in many superficial calcium without significant thickness or circumferential calcium. When you have an eccentric calcium, means if it's only on one side, when you expand, the non-calcified segment expands, but the calcified does not expand so much. That may lead to rupture, vessel dissections, and perforations. Now, non-compliance balloons, we all know that in simple coronary lesions, pre-dilation, post-dilation with non-compliant balloons at high pressures, safe, and they give you better scaffolding and stent expansion. And we use semi-compliant balloons only for pre-dilation, might lead to inadequate stent expansion, and post-dilatation with non-compliance will be required. All of us have understood this. When you look at this very high pressure, which you call OPN, which can go up to 30 atmosphere to 40 atmospheres. In a car tires, the pressure is about 5 atmospheres. And now here we are going at 7 times the pressure in your car or an SUV, you can imagine. That much force is going to be transmitted here. But the beauty of it is, even at those atmospheres, it may increase its diameter by about 10%. So if you take a 3 mm OPNC, it may go to 3.1 or 3.2 millimeters. So that's great advantage. It's a dual layer, low profile. Low profile not compared to NC balloon, but low profile compared to IVL or a cutting balloon. Can exert super high pressures, about 35 atmospheres, and simple to use, very effective. No, not so much risk of shoulder dissections and hematomas. When conventional NCBs fail, high pressure non-compliant balloons provide you breakage at that particular point. Usually you have 1 or 2 segments which will need really high pressures. The potential risk is coronary dissection, perforation, localized wall injury, may provide substrate for restenosis because you're applying too much pressure on that, and that activates your media and intima for smooth muscle proliferation. The lesion selection remains challenging. You cannot use OPN in every lesion. If you have imaged and you've tried non-compliant balloon, NC balloon, it doesn't, that's when you look at this. What's important? Look at their change in diameter. 2 may just become 2.2 at those bursted at 35 atmosphere. From 2 it will become 2.2. From 3.5, 3.91, so factor that in. Whenever you are using a OPNC balloon, take 0.5 lesser. Because when you go at 40 atmospheres, you may increase by about 10%. So factor that in. Don't take 1:1 if you're doing in a de novo lesion, not within the stent. Very high pressure dilatation balloons, they yield good result, but long-term results are not well documented. Now, we're all fancying this new cutting balloons. We know it's a great new tool. It's made life very easy for in the days of good angioplasty, whether it's DCB, ISR, or de novo lesions. It was first developed, can you imagine, 1980s by Dr. Peter Barrett, and it was called Barrett balloon, and then 3 or 4 atherotomes are embedded on the, this plastic balloon, and it's wrapped inside. What is important, provides focused force. When you expand this balloon, they apply that force significantly higher at certain points, more than rest of the vessel. So the high pressure is transmitted predominantly at 3 diagonal portions, so you get to break them into 3 different pieces, so your compliance can significantly increase because you're reducing thickness of that constricting band, either fibrotic or superficial calcium, predominantly in this, so they become 3 different pieces rather than one single ring. It provides focus force at low pressures. Even if you go at 6 or 10 atmospheres, it gives you equal at those points of contact with the atherotome, you have at least 50 atmospheres of pressure. The rest of the balloon is at 6 atmosphere. The contact with the vessel is transmitting 6 atmosphere, but these atherotomes are transmitting 50 atmospheres. So what is the advantage? The medial injury is much lesser. The activation for restenosis is much, much lesser. Only challenge is difficulty in delivering in certain subsets. So before you take this, doing an NC is always better, and then switch over to this. How does it work? You see this, it's wrapped inside. There is plastic balloon that is wrapped, and then when it opens, this is how it comes in contact. And when it's fully open, that's how it gets into the wall, and it gets you this dilatation. So diameter of the cutting balloon is selected approximately 1:1:1 if it's a de novo, but if you're within the stent, you can go to 1:1. Balloon to the reference vessel diameter. Oversizing increase the risk of perforation, so be cautious. Balloon lengths are often 10 to 15 millimeters. We still don't have 20 millimeters, so many. Should be, look at this, remember this, should be inflated and deflated very slowly. 1 atmosphere every 2 to 3 seconds to avoid damaging their structural integrity. Suddenly don't go up like a regular balloon. Just go very slowly. Allow them to come up and engage the lesion, and then go at a higher pressures. Both, not only while inflating, but also while deflating, so that you can rewrap, safely take out without causing injury to adjacent vessel wall. Some authors advocate, we also do, when I want more cuts, I come back, rotate, and then go again, so that it engages different fibrotic plane and gives you more cuts. You can do that as well. The cutting balloon angioplasty before drug-eluting stent implantation for the treatment of severely calcified, means superficial to moderate, not very deep. It's safe, effective cutting balloon angioplasty, and it gives you 2 things. It increases the compliance. It gives you, without much, at 6 atmospheres, it gives you least of your hematomas and dissections, but those deep cuts also gives you good penetration for drug to elute. So cutting balloon angioplasty before DS implantation in severely calcified lesion appears to be more efficacious, including larger final stents or lumen areas and larger acute lumen gain, because you're cutting that constricting bands into 3 portions at least, or sometime even more if you have done multiple times, without increasing the complications of up to 6 months in terms of MACE. So that's a Wolverine is a fantastic atherotome based cutting balloon. Then you have a scoring balloon. Here you have a semi-compliant balloon with 3 to 4 rectangular nitinol based struts. You can see them, helical pattern, they are wound on it. And again, what they do, the same thing, reducing the mechanical trauma exerted on the vessel wall, lower risk of dissection, and it's a little more deliverable than Wolverine. Again, when you inflate, you can see this. This is what you want to achieve. In a deflated form, this is how it looks. in an inflated form, it'll push, but at those particular points, it'll give you good cuts. Now,
Dr.
coming
Girish,
to
sorry to interrupt you. Yeah, you'll have to go a little faster, because
Sorry.
you have 10 more minutes.
Thank
Sorry.
you, sir.
Yeah, thank
so
you.
I'm done because I just wanted to get that thought process. Now we know how we are going to approach it. Algorithm, we know moderate to severe calcium. Imaging is absolutely essential. If you have a deep calcium, directly go to scoring cutting balloon. If you can have got a good fractures on the OCT or IVUS, if you have yes, then do a drug-eluting stent and post-dilate for at least more than 18 atmosphere and do the final OCT or IVUS. If you have superficial calcium, again, if the score is less than 2 on OCT and on IVUS less than 2, then you can follow the same thing, NC, scoring cutting balloon, and then do a OCT if you have got good cuts, and then implant either a stent or a DCB, and at 18 atmosphere, final. But if you on a superficial calcium, if you have a OCT score of 3 or more, or an IVUS score of 3 or more, you will need either IVL, orbital, or rotational atherectomy. And then if you have an you have a nodular lesion on the assessment, I think the best would be orbital or rotational atherectomy. IVL has shown some benefit, but ideally would be to debulk. If you're using rotational atherectomy, you have to bias the wire. If you're doing orbital, you don't have to. It automatically has both antegrade and retrograde. It gives you much better. If you're uncrossable, people speak more about rotational atherectomy, but it also can be done with orbital. Let's go into that. Let me show you a case, 70 years old male who had moderate dysfunction. This is how the presentation is. IVUS was done for this case, and once you know, you have to do, the best thing is if you can use a regular NC balloon, and then Wolverine cutting balloon was used in this case, and imaging was done here, IVUS, you can see that. The images were not opening, so I've just kept it aside. And then you have this, dedicated left main stent with great custom built for left main Megatron. So you had a good expansion, do the pod proximally, and then dilate, image, and come out. This is your final result. So cutting balloon does work if you have imaged. It's not very deep, not circumferential, not very thick. Just the regular cutting balloon should suffice. Everywhere we do not need atherectomy or an IVL. So, and then tips and what is a cutting balloon? Should be used primarily to create fractures in the calcium rather than optimally dilate the lesion. As we were discussing, due to increased risk of perforation, this decrease the size of cutting balloon by about 0.5 millimeter compared to the vessel, and if multiple dilatations are required, move it in and out. Then you have a lithotripsy. It's an ultrasound which emits the sequential sound waves. They expand and collapse the balloon, creating about 50 atmospheres. Look at the pressure that it creates. The MPa, if you really look at it, it says 1 MPa is about 9.8 atmospheres. It creates about 5 MPa, which is about 9.8 into 5, is about 45 to 50 atmospheres when you use this. This is how the mechanism is. When it comes in contact with high amplitude ultrasonic wave shock waves, when they come with differentiating acoustic impedances, it causes more damage than which have tissues which have similar acoustic impedance. That means soft tissues, it does not hurt much, but when you have an interface between hard and soft tissue, the hard tissue gets damaged. You can look at this in the water, 1,500 kilo, then here kidney 1,600, muscle 1,700, but look at the calcified tissue, 7,800 per kg. So this is how we do. We all know how we generate. It's a compressive shock wave. And look at a case. Even before you inject, you can see the tram track calcium. So you got to deal with one strategy is not going to be enough. So it had to be multiple strategies. First, get a good atherectomy. Why? You also want to debulk. not enough to just change the compliance of the vessel, but also gain larger pre-balloon diameter by converting that obstructing tissue into finer powder and have a larger lumen left. And imaging is very, very crucial. In short, due to time, I'll just show you what was the MLAs. And you always look at how much was the 270 degrees. Calcium, look at the tight, how it is, the thickness of the calcium, the eccentricity. Don't think that the calcium morphology in the long lesion is going to be same at every location. It's going to differ from this 5 millimeters to this 5 millimeter, this 5 millimeters. So you need to have that strategy. If you're doing an orbital, you can't do what you're doing here in this segment where there's no calcium, because you may cause significant damage to soft tissue. So understanding which segment of the vessel has what thickness, what diameter, and what tool should work in which place. So here cuts were noticed following the, then we used again OPNC to hope that it would crack, but it did not. Then eventually we took a 3x12 IVL in those areas where OPNC did not yield. See, you have only limited pulses on an IVL. So if you have to use between 2 IVLs for a very long lesion, better is you do OPNC first and see whatever you can crack and open, whichever doesn't, keep your impulses for that lesions. That's been our strategy. And eventually, again do an imaging before you take a stent in. Don't implant a stent and then do. Otherwise, if you were not prepared the lesion well, come back with OPNC again, or preserve 1 or 2 impulses, can go to that particular segment to treat them. But you can beautifully see so many fractures, lumen gain is significantly high, and then eventually stented. And look at how beautiful you can gain by it. So it's a lot of looking at those images sincerely for 5 minutes at every 5 millimeter segments, and which tool to use where. If you're used in rotablation, it can work like an orbital if you go in that particular segment and drill very slowly at 90,000 to 1 lakh RPM. You keep it spinning for a longer time at one. Otherwise, rota, you just go in and come back to drill a hole, but at times you can gain some more. So eventually we got a final OCT run. The vessel looks good. So that is selection of our tools. And tips again, OPN, you can go up to 35. If you can't, then open your IVL. So rota cut, many a times, see, look at the ostium. We may not need very often, this is an ideal case for orbital, but we didn't have it on that day. People think, sorry, am I late? Okay. Wind up. Very kind. So this is the part I would have. One last I want to show you on this orbital.
Yeah, show this. This is the main topic.
This is the main topic. Orbital we wanted. It has got 2 actions. What is it? It gives you differential sanding. That means it converts all that tissue into fine powder and gives you a larger lumen. But also because it's spinning and hitting on the wall, it causes fractures, increasing the compliance. So it's got a dual mechanism compared to many other tools. Like, if you're comparing it to a rotational atherectomy, it's drilling a hole. But here, it's not only drilling a hole, but also going all around the vessel, causing these fractures. Can you see this? Here you don't get so many fractures unless you take a very big burr and go at very slow speeds. That's the difference. So you allows 360-degree vessel compliance changes and can treat from 2.5 to 4 millimeter vessel with a single crown. Here you'll have to use a 1.5, 1.75, 2 millimeter depending on the diameter, but here one crown can do all that work. And the greatest advantage is this. Look at that. When you use a rotablator, it works only on one side. It's all wire biased. Wherever the wire, it goes on the wire. But look at this. It spins all around. It's only spinning on one axis, but it goes all around it. So that if you have to treat any circumflex ostium, when you push it forward, antegrade orbital, you are doing the outer, ablating the outer surface more because it's touching that surface more. But when you do a retrograde sanding, it's more towards the inner surface and sands more. So it's got a dual area management with either forward or retrograde. When you compare to IVL, what is the advantage here? You get a sanding for deliverability. That means you're removing the tissue, but also giving a nude area for drug to be delivered compared to an IVL when you look at it. So I think this is one case that I would want to show you. I think image is very, very crucial. And with that, I'll conclude. See, when you have nodules like this, can you see this? These cannot be treated by any other tool better than orbital atherectomy. You can see that once you do an orbital, you have shaved off a lot of that nodule, and you can go back and do multiple times. And before stenting, we do at least 2 or 3 OCTs before you implant a stent. Okay, so probably with this, I would conclude and show you. Sorry, this one. If you can just appreciate a lesion like this, if there's a hemodynamic compromise, very critical lesion, the one which leads to minimum hemodynamic compromise would be an orbital, because it's not plugging the tightest portion, but it's rotating. Always you have side blood flow. If hemodynamic instability, orbital is the best. Thank you. With that, I'll conclude.
Yeah. Thank you very much, Dr. Girish. It is an excellent presentation. We highly appreciate. What we'll do now is we'll have the case presentation and we'll have discussion along with the cases, because we have 4 excellent presenters, so that we'll use your expertise to see how they have done, and let's discuss it out. So I'll invite Kirti to start his presentation. Before Kirti starts, we just want to give a token of appreciation to Dr. Navasundi, and I'll request Dr. Bhavesh and Amit to do the honors. Yeah.
Thank you, Doctor.
Yeah.
Pleasure. My pleasure.
And I would request the presenters, just for the sake of time management, to present one case and have a good discussion rather than present multiple cases maybe. Yeah. So it all depends on you, whatever you want to present. Yeah. Thank you.
Thanks, Kane. Thanks for inviting me. I'll get on to the case. A 73-year-old, effort angina, risk factors, hypertension, and family history, good LV function, and a calcium score of around 2,500. The best part of the story starts in the CT scan. And if you can tell, the CT scan tells us that the LED shows a seriously significant calcium proximally and some flakes of calcium which are more eccentric as we go downstream. It also tells us in the circumflex, proximally there's not much, but there's an area that could give us trouble. So much before you go to the cath lab, we really know what's going on. And this is the angiography, if you look at. Moderately calcified circumflex and the LED as well. Now, the plan is to perform an angioplasty to both these arteries. And what are the challenges that we need to overcome? The challenges are, first challenge is always crossing these lesions. And the next is expanding these lesions. And the entire calcium plethora of all devices are based on these 2 problems. So the first thing is, how do I check for crossability? So first thing I do is I have difficulty to cross with IVUS. So of course, there's been so much of OCT, I might as well throw in a little bit of IVUS today. So in this case, we said, let's look at the circumflex artery and look at an IVUS catheter, and our IVUS catheter doesn't want to go. So the fact that the IVUS catheter doesn't want to go, our next step is to look at a microcatheter. Now, if the microcatheter goes, then yes, we have two options. We'll have rotational atherectomy or we'll have orbital atherectomy, because now we can put in a Viper wire or we could get in a rota direct wire. Sometimes we could get a rota direct wire even without. We can get some of these wires across even without the micro. The whole idea is, can you get a specialty wire downstream into the artery, whether with a microcatheter or without? But if you cannot, then your options are Tornus or ELCA. But if you can get a specialty wire, then your options open up. In this case, we were able to, so we got an orbital atherectomy. And the reason I'm showing this case is because Kane asked me to show you orbital atherectomies. So we took in a 1.25 crown. And as the story goes, the crown is advanced. There's 30 seconds to play with the crown. Typically don't run it beyond 20, because when you run it beyond 20, the heat, you can start fracturing the crowns. So you've got to be careful. And even if it goes as against what we do, principally when we use rotablation, we never stop and stall the device distally. Over here, it's okay if you're going to 20 seconds, and if you're distal to the lesion, just stop it at that and give it that cooling time. So you can go proximal, distal, you can sand antegradely, and you can sand retrogradely, and in some complex lesions, it might be better to go down dynagliding and then coming back sanding. So in circumflex arteries, which have two bends, it's a great idea to do that technology where you sand these arteries distal to proximal rather than proximal to distal. And we achieved that. We went all the way down, and you can see you have to be very slow in the sanding. And most of the times, use 80. In a very exceptional artery, when the artery is big, come back to 120. And when I use 120, I typically use it retrograde, coming back. So here we use 80, and then we used a 120. And again, once that is done, the IVUS crosses. So the whole idea was to establish the IVUS crossability or get the imaging of this artery. So the first thing that you've learned is that using the first tool for calcium cannot be image guided. So the use of rotablation, use of orbital atherectomy and excimer laser is not image guided at all. And the scores tell you that if the scores are high, use rotablation. I think it's a little bit of a mismatch or a match over there, because most of the times when we use atherectomy devices, IVUS catheters and OCT catheters don't even go into the lesion. And that's an important point. So we do that IVUS, and let's do the IVUS. So the IVUS, what does the IVUS do? The IVUS tells us that distally the landing zone is 3 and proximally it's around 3.5, and we need to stand from this to here. But what the longitudinal view tells us, and it concurs with what we saw in the CT, that there was an area in the calcium which is going to be a little more of an issue. So in my longitudinal view, whatever the calcium distribution and plethora all across, I know that my cutting balloon is going to be fine here and here. This area I need to test. So this is my ring of calcium. Based on this, I need to know that I need to have a technology which is going to expand, and it'll have to be beyond this, so it'll have to be 3 plus at least. You could take a 3, some people would take a 3.5. It all depends upon how proximal to the landing zone. If it is close to the proximal, you take a 3.25. Distally, you can take even a 2.5. But it was way between, so we took in a 3.0 or 3.25. And so we took a Wolverine 3.25, and the question now is, are we going to test the next thing? Crossability is done. The next is expansibility. So we expanded all the way from downstream here up, and this was the area where we could not expand at 18 atmospheres. So very clearly, my cutting balloon at 18 atmospheres, 3.25, fails to expand. So this is that tight lesion where we go in and deploy an IVL, and 60 pulses later, it appears to have completely expanded. So the question is, did it really work? Yes. This was the IVUS at that point, the IVUS image at that point. And once we do a cutting balloon, it still doesn't expand. And here, it expands. Now, the point I'm trying to make is, it did not require me to understand thickness of calcium here. Because whatever the thickness of calcium, my clinical problem was unique. I'd done an orbital, and post-orbital, my balloon was not expanding at a high pressure, so I had to escalate my technology to a shock wave. Now, my shock wave might not have worked as well. So then I could have gone to a high sustained pressure to an OPN as well, but I could have used more, or I could come back to a laser with contrast. These are all options that we have. It's how you play them, but this is how I play them in my cath lab for cost effectiveness. So we know that we need to stent, and here we are. We're going to stent all the way to the circumflex is done. We go to the LAD. Again, we look at the same things, and IVUS catheter does not cross. And since we have an orbital atherectomy already open, sometimes if you have opened a device, it is okay to use that device in the other artery as well, and this might be cost effective. The only one thing that I say is that if you're using a rotablator, don't use the same wire in the circumflex and the LAD. Throw the wire, take a new wire for the LAD. The reason is because a circumflex artery is bent, and a lot of things happen to the wire. And if you have bends in the artery, you just increase your grade of difficulty in doing the case. Change the wire. The burr will still work without a problem. The wire might make it easy for you. So here we went and sanded using the same technology. So we use the orbital. And the question is, how do we deal with it? Yeah. So we use the orbital, again, the same way. Around 80,000, 3 runs, and then a run of around 4 runs of 80,000 and 3 runs of 120 on the way back. And we look at calcium on these images, and we realize that when you look at this calcium right here, there's that little eccentric calcium, more like a eccentric protruding, which commonly referred to as your nodules in the OCT. But here we're looking at, and you can see that the reverberations indicate that my orbital atherectomy has done something to it. It's polished it. I don't see too much happening here, but I see that though it's there, maybe this kind of a calcium will respond to Wolverines or cutting balloons, if I may say so, because there are more than one cutting balloons now. Wolverine is not the only cutting balloon that's there. And here we have a nice dark calcified area. These are areas. So when I look at my IVUS image, here I think my Wolverine might work or the cutting balloon may work. I may require an IVL here. So we've already identified from the IVUS that which areas I may require. So I've got an IVL opened. I already have some pulses. I know where to deliver. So we take the Wolverine, and any of these cutting balloons, if you have to work in calcium, once you size them appropriately, they don't work unless you go to 16 to 18 atmospheres, sometimes 20. So using a cutting balloon and using it at 6 atmospheres or 8 atmospheres is like not using that balloon at all. Don't waste your money. If you're going to use it at 18 atmospheres or don't use it. And then at 18 atmospheres, we realize that it is still unexpanded. You can see that here it's completely expanded in 2 fluoroscopic views. Here it's not expanded. So that's where we need to deliver the IVL. We do that, and post-IVL, IVUS shows great cuts. If you have to compare this, you can see the rings which were previously, this is not working, but you can see the rings right up there which have cracked. These are the corresponding images. And once you know that you've achieved this kind of fragmented calcium in this artery, you know that this artery is ready for stenting. And of course, you can go ahead and stent it and complete the case. I think I can't go on, but I'll stop here and we can discuss more from the case that I presented. Would be great.
Yeah, Rajiv, VT, Anand, any questions on this? I have a question, Kirti, just for to bring up the discussion. Now, you have used sort of 3 or 4 devices in the same patient. And by the time you realize that cutting balloon does not help and your this thing does not help and you want to go to IVL, it took quite some time. So my perception was if you had an OCT done in between, maybe you will realize that this is a straight away case for IVL or something like that.
No.
So what is
let
Ronnie
me
got
let
to
me
say
let me
with this
let me
and, yeah.
so let me how did I get to this? How did I get to this? We got to this because if can I show you a slide and explain that? Just one slide of how we have our little. Yeah. So it's about cost.
Yeah.
So when we first had IVL released, we used IVL based on imaging. The minute imaging showed concentric calcium, we used IVL. So in my small practice, I ended up using 35 IVLs in the first year, which is a very large number, I thought. So we changed our strategy to saying that whatever the calcium, whatever the distribution of calcium, it doesn't matter whether it's concentric, whatever. Before we get to that, we will put a cutting balloon. Then we realized that we were able to deliver and expand even concentric calcium with cutting balloon with this strategy. And we started using not more than 15 balloons in a year, IVLs. So that is a serious cost reduction when you look at overall consumption of material in the cath lab. And we realized that this is an effective strategy. Now, to put that whole format forward of how do we plan, I think I'll go to this other slide, which is a little more active, where you'll be able to appreciate it. Here, this one, right here. So we start off with the IVUS catheter. If it fails to cross, you take a micro catheter. If it fails to cross, you have Elka, Torner, small balloon. But if it successfully crosses, you use a rotoblator 1.5 most of the times, or an orbital, or an Elka is an option if it doesn't cross again. The whole idea is to cross the IVUS or OCT catheter. If the IVUS or OCT catheter crosses, then based on all your analyses of that image, you may think that this is a favorable wire bias where a rotoblator upsize will work, or no favorable wire bias with an eccentric calcified lesion where orbital might be a choice, but Elka is also a choice in calcified lesions in some of these areas, but with caution. And I think we're looking at doing more work, and once we have that more work going in with safety, I think it might become a clear indication. And once you've done crossability, then you come to expansibility. And here's the question. The first balloon I use is a 1:1 size of the distal lumen, whether I be taking a Wolverine, or I take a scoring, or I do an NC. I've given up on NC. I don't use NCs for this because it doesn't. And when I take a Wolverine to 16 atmospheres, at the atherotome, it's 3x. So it's 16 into 3, so it's almost like 50 atmospheres of pressure. So when I use it at 10 atmospheres, at the atherotome, it's 3x, which is 30 atmospheres of pressure. So you're already using a very powerful tool, and in combination with a rotoblator or with an orbital atherectomy, it's very powerful. So I use a cutting balloon here, and we are able to almost get 85% of our work done with this level of, at this level. And then if it fails to expand, you use an IVL as your next device. And if that fails to expand, you can use an OPN again. But there are cases where all this fails and then you go back to bailing out with orbital high speed or Elka with contrast. And I think this is an indication which is emerging, which we'll kind of talk about.
Sure, thank you. Because that's very good. But what I wanted Ronnie to say, I just want Dr. Ronnie's opinion on this. Do you have something different to say? Because we just want to learn, all of us here in the state.
No, I think he's absolutely right. See, imaging guided calcium modification only works when the imaging catheter crosses.
No, I agree with that.
So in most of the calcium, like the ones he showed, the imaging catheter doesn't cross. The micro catheter doesn't cross.
No, now I have this thing to that before you go ahead. We all have this problem that imaging the micro catheter doesn't cross. So wire has gone. So if we get a 2.5 balloon in a 3 artery or a 2 millimeter balloon in a 2.5, so we always do a balloon because we don't have Elka. So how many centers have Elka? You don't have it. See, he's been lucky and he's a prolific operator.
Can you show that slide, Kirti? Same
slide. So we do a balloon dilatation.
Agree.
And
if
then do imaging. The idea is to get imaging catheter in. That's the way I look at it.
See, if you can get an imaging catheter inside, then you follow the imaging catheter
No,
guidelines.
then what happens is with a simple balloon, you have got your imaging catheter.
May I
Then
intervene?
you decide what you want.
May I say something? So, we started off around 10 years ago. I thought, okay, my imaging catheter is not going, I should take a 2.5 balloon and dilate it, which is what most people in the room want to do.
Yeah, correct. And save one cost of atherectomy. See,
so listen. So listen to me.
Was balloon.
VT, 1 minute. Just 1 minute. Let's finish one at a time.
Yeah.
So when I started doing that, Kane, what did I realize? That once you get seduced, the balloons are so good that they will cross. If you make a little bit of an effort, a 2 balloon will go down. But the minute it goes down, now you're seduced to dilating it. And once you expand it with a 2 balloon, and if you decide now that you need an atherectomy, even though it expands well, you still may need an atherectomy. And when you need an atherectomy after a balloon dilatation, that's when you start getting into trouble. And that atherectomy is not as effective, in my opinion, than when you use an atherectomy up front. And I think there lies the problem. And then you get seduced with a 2.5, and then with a 2.5, now you want to put a 3O stent, and those 3O stents don't expand.
Okay, just one comment.
Point well taken. Last comment from VT, and then Dr. Anand Rao,
I
please
just
come.
want to inform Kirti. Yeah, same slide.
Oh, you still want to see the slide? Okay.
No, I want to just ask you, in your algorithm, balloon uncrossable means atherectomy, that is fine. Balloon non-crossable or imaging catheter. But if it is there, why not balloon, as Kanye was saying, the whole
Yeah. So if it is success,
Eclipse trial was balloon versus orbital, and the end results were the same. And that without, atherectomy, the catheter doesn't cross, that was not there.
So VT.
And the crossover.
VT, when we talk about an eclipse trial,
they compare these 3 tools and they're trying to see where does the media get damaged. And a high pressure balloon damages the media much more than these atherectomy devices.
Okay.
So there is a lot of sense in what he says, that, debulk the lesion rather than just blast the lesion with a large balloon.
Yeah, so I am not saying that. So just dilate with a balloon, get your imaging done.
Catheter inside.
Otherwise, all we have discussed from morning is at a loss. And I don't think it is a valuable discussion that we have made. So we should remember that imaging is very important in there. Okay, so next, Dr. Anand Rao. Yeah.
Thank you, sir. Well, I'm going against your this thing of presenting multiple cases, but I'll make sure I'll finish in 10 minutes. I'll give some time back to you. So straight away going to the cases. This is, as you see, a very calcified LED, tortuous a bit, but laden with calcium from proximal to mid, tram-tech appearance, and a tortuosity also. So probably, I don't know, probably Rota would have been a better choice. I tried to pass imaging catheter. The imaging catheter could not go. So I started with orbital in this case, and then 80,000 rotations. Went with antegrade and retrograde sanding. Couple of things to tell about orbital. I think most of them are using it. It has to be extremely slow, but the Rota operators, try to push in the catheters like a Rota. It doesn't work like that. It has to be very, very slow, and 25 seconds on and 25 seconds off. So antegrade and retrograde sanding both are available to us. So did the orbital, the entire artery, you can see the long area to debulk. Once that was done, there was some slow flow noted in this situation. I thought probably the proximal area is not well ablated, so I did some more sanding, and the slow flow, no flow is very less in orbital compared to rotational atherectomy, but it is there. It's not 0%. However, it responds to intracoronary vasodilators very well. Then try to pass catheter again, as discussed previously. The imaging catheter could not go, so did a pre-dilatation again. Now my imaging catheter could go inside, and then we got some OCT images done. If you can see, a lot of things are happening over here. There are cracks develop, and there's nodular cracks over here, and there are a couple of nodules over here. So did some more work on that. We realized, it needs a cutting balloon also. So did a cutting balloon after this. And so once that was done, we had a uniform expansion of the balloons and started placing the stents. And then post-dilatation with high pressure, we had the diameters known with us with the intravascular imaging OCT, and then nice and circular diameters you get at the end of the procedure, and this is what you want. The beauty part of the orbital is you get this kind of circular expansion because it not even just spins but cuts deeply also, so that the MLAs become better. So that's a final result. This was our initial experience of orbital. Then this was, I was called to do this case. If you can see, there's a nasty bend in the circumflex, this area. It's almost like a 90 degrees bend over there. So I took various views and didn't know it was very calcified. But in this center where I went, there was no rotational atherectomy was not available, and only orbital was available. So I thought, let me put in a wire and understand what's going on over here. And believe me, there was no imaging also in this. So this is one of those areas, probably the 90 degrees bend, probably orbital atherectomy is going to be risky. So I thought I will do the proximal ablation over here, and then with glide assist, maybe I'll cross that bend and do a retrograde sanding. That's what my thing was. We have done that in left main osteums and RCA osteums. So glide assist, go inside first and then do a retrograde sanding. That would be much easier. So that's what I did in this case. And then after that, achieved a good reasonable luminal gain over here. And then took a 2.75 by 38 stent. And that's how the end result looks. Just to show you, even tortuous bends like this, if you are careful, you can do an atherectomy, orbital atherectomy in this case. This was also same patient has a diffuse, very badly diseased RCA, and then the beauty of orbital is the Viper wire is an excellent wire. The wire just goes in. You don't have to do like rotablator wire. You don't have to exchange it over a microcatheter. Viper can be used as a primary wire, and it just walks in. It's a fantastic wire, and then. You see this orbital. This is what should not happen. I'm trying to force this. This should not be there because the guide should not come out like this. However, I did an orbital. The whole area was, burying was done. This was all 80,000 because this vessel is not more than 2.75. So I think 80,000 is what we want over here. And that was done. And then routine angioplasty, pre-dilatation and putting in a stent. And this is what you come out when you finish the cases. Last and final case. Again, this was interesting. This patient came with an ACS. As you can see, the LED flow is not much. And if you see, the LED flow is not much. This is an acute patient. Hemodynamically stable, means blood pressure and all that was good. So calcification was quite too much, and we took him as a PAMI. Now I cannot change my decision and go for thrombolysis or something like that. So what I did was I passed a wire with a great difficulty. I had a balloon going in, and NCN cutting balloon failed to open up heavily calcified nodule over here. So TIMI3 flow was established. I waited on the table for 15-20 minutes. There was no dissection. There was no closure of the vessel. I was very scared to do rota in this patient because his blood pressure was now falling down. I don't want to do more distal embolization. So I thought I'll plan it after 48 hours, keeping on heparin, all those things. I took him back and did a orbital so that hopefully the slow flow would be much better. So this was the initial image. The TIMI3 flow is good. Did an orbital over here again at this place. And then routine angioplasty, did the balloon dilatation, protected the diagonal with the wire, and then placed stents over here. So this is how an acute patient can be salvaged if you want. And there was no distal embolization much into it. So my take-home message is orbital atherectomy is safe and effective calcium modification tool for complex coronary and peripheral lesions. It facilitates optimal stent delivery and expansion, improving long-term outcomes. Proper patient selection and adjunctive imaging, IVUS and OCT are essential. I think this point has been stressed over here quite a bit, which is very, very practical, that if you want to understand the device, you have to do imaging. Remember, debug, deliver, deploy, and dilate. This is what it is. Use is not just as a device, but as a part of comprehensive calcium management strategy. Thank you very much. I give 5 minutes back to you.
So any comments from our faculty?
Yeah.
I think in the last case, if you had just aspirated the thrombus and done an imaging, you could have avoided a lot of fear of slow flow, etc., etc., etc. Because you know what you're dealing with.
Absolutely. Absolutely. Point is well taken. The problem is we had a difficulty. The initial balloons were difficult to go in, and then that was there. Of course.
Yeah, good afternoon, friends. Good afternoon, CSI, for giving me this opportunity. And my case is simple, not so complex like what you have seen, but has some important message also. So yeah, this is about a 70-year-old minimally active male diabetic on OHA with poor compliance, non-hypertensive, non-smoker, sudden onset chest pain, breathlessness, sweating within 1 hour, brought to casualty. ECG showed inferolateral MI. Echo showed a large territory with EF of 35, pulse rate of 110, BP on NORAD was 8 ml per hour, single strength, on NIV 100% FiO2 97, EGFR 43 and taken for PAMI. So you can see the amount of calcium on the left side. This was femoral root and this is the shoot. Again, you can see the calcium, you can see proximal, mid and a distal LED lesion. And you can see some collaterals going, the circ is occluded. And now you can see the culprit vessel, which is the RCA, and the amount of calcium and the bends and some distal flow. However, fortunately, I did not encounter much and did not have to use the usual discussion today of atherectomies and IVLs. So I could finish this. And so that was the end result where I left with some plaques distally, but good flow. And then he was on NORAD and for about 5-7 days he took time to recover gradually. So on the 12th day I took him up for the left side. And before I took him up for the left side, you can see there was a good collateral going right up to the circumflex here, right. So you have a pointer still working? Yeah, fortunately, yeah. Got recharged. Good. So then I thought that why just let us do the left and see. And here in this case, I mean, the other option was us to strategy as to what to do, send him for an elective CABG. He didn't want any further intervention and therefore he didn't get discharged. He says, finish the left and let me go. Discharge and plan or perform PCI. If PCI only to LED or LED plus LCX, I decided for LED calcium management, image guided, elective rota or orbital following cutting balloon and IVL, the Punamya way, or you can do Because I didn't know that was his strategy, before I came here. So I put it here. Otherwise, I would have labeled this Punamya way. Plaque modification followed by hybrid treatment, that means stent plus DB or something like that, and plus minus MCS. So this was what I was all going on. And if orbital, so the reason. Pardon? Yeah. But now you can patent this after my talk. De novo wiring with Viper or wire exchange with microcatheter crosses, which lesion to sand first. So the reason, I'll tell you, one of the reasons why I was, So there was one lesion here which had a fairly good lumen, a very tight lesion here and another lesion here. Now if I were to take rota, maybe it would not help me here. It would help me in the mid lesion and possibly in the distal also. So I thought that orbital would be good because it can give me bigger lumen here. It can cross this also and the distal lesion. So in this case, this is what I thought, and therefore I chose orbital. And then this was which technique of sending. People use antigrade and retrograde. I reserve that word only for CTOs, so I use the word forward standing and backward standing. What speeds to adapt and chances of slow flow if it occur. What treatment to do. So this was the usual Sion wire as the Viper wire. So that is another thing where Anand is here. So when you do orbital, see that you have two wires. I went with a de novo Viper wire and it got kinked over here. The shape became kinked. And then I lost that. And fortunately, these guys had second wire on board. So then I used the Sion crossed with it and then used a Corsair Pro and then took the help of that. That did not cross. You can see the guide backing out, the wire coming back. So then I said, okay, what I did is that I removed that Sion. I sort of plunged this in the lesion and then used the Viper wire and it went in. So without doing anything else, because otherwise, as I said, I could have used a small balloon and pre-dilated and then did, but this worked. So right, now comes orbital. So now which lesion to sand first was my question, whether the proximal, the mid or the distal. Since this was the tightest, if I sand here and if it gets blocked over here, then I will be in big trouble. So I used the mid lesion which was the tightest, and then as everybody has emphasized, slow sanding, slow motion, patience, 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 because if you are a rota man, you have to learn how to be more patient with orbital. So that we did, and then it went through gradually, and then now the thing is, always remember about jumping. When you are doing such very tight lesions, the final it may jump, and which happened in this case. I don't want to push you further. Then I went to this. Now this lesion, unfortunately at 80 RPM was not giving way. The distal one, which looked fairly good lumen, and we had to go up to 120 in that case. So we did that also. And then as everybody is anxious about slow flow, no flow, we checked that also. Now I think in this run we'll be able to see that anyway. So we took one check shoot. Everything looked fine. So I said, why not do here? There is no imaging yet. So before I remove, let us finish this off also and then maybe do imaging and decide upon the strategy. So till this, so far so good. This was of course after vasodilators. And then this. So this, as everybody was saying, that this could be a calcified nodule, which I thought was there with so much of calcium. Again, slow sanding and everything. This also jumped. And then held loose. No flow, slow flow, blood pressure dropping. NORAD, adrenaline, everything. Used a microcatheter. And then gave a lot of vasodilators through this. At the anesthetist side was giving inotropes and all that, and putting on the NIBP also. So after all that, I got this flow through the microcatheter. So almost like 10-15 minutes of anxious moments and the blood pressure dropping, whether to do or not, and then remove that, give vasodilators, and this was the run. Now this run was on 16 ml of NORAD, and besides a slow Nicoran drip also. And then I thought what to do next. Should I go ahead? I think that this is on the other view. Again, still good flow, all branches preserved, everything. So next what? On 16 ml, 100 by 66, pain tolerable, ST settled, dye 50 to 60 ml. MCAS, IBP was the only choice. We don't have on board any impellers, neither the patient would have afforded. So what to do? Image and proceed ahead or pause and shift? I gave terofeban also during that no flow, slow flow situation. Well, I quit at this stage and said that let me stage this procedure and then take him. This was about 2 weeks back, and Professor Kane phoned me up for some interesting case. So I said I will show you one case where I had to quit after post-orbital, post-plasty, minor, then good urine output, tyro, and after about 6th day he was discharged. So what does literature say? 0.7 to 0.9 in orbital 2 trial was the slow flow, which is quite less here, but maybe because of the large plaque burden or low EF, or whether it was too early even on the 12th day, I would not say, but we all say complete trial, do it, finish it, one sitting, pre-discharge and all that, but sometimes that also should be very judiciously followed. This happened to be a standalone orbital, albeit as a rescue strategy. Standalones have been tried in peripherals, but not in coronaries. But similar situation, standalone strategy in rota we have done. Many, especially in high bleeding risk, with hemoglobin of 8 grams and 9 grams coming as PAMI, short lesions, just do orbital TIMI3 flow and that's it. Thank you.
Sir, I want to ask a question.
Yeah.
In the LED, you should have directly with a 2 millimeter balloon.
Proximal lesion?
No, the right lesion. When you done the imaging, you should have made out the thrombus load, the calcium, because on the angiography the calcium did not appear much. On the angiography.
No?
It did not appear much.
Sorry.
So I think probably directing with a 2 millimeter balloon and doing an imaging would have probably changed the whole strategy.
Yeah. So after doing the mid and the distal, I showed you the flow, TIMI3 flow without anything. There was nothing there.
Something was there proximal.
Yeah.
Proximally, I think it was though the lumen was good, unless you do. But there the orbital, see, first time I just crossed it because the lumen was quite big enough. When I went to do the orbital, I will show you the orbital run, how it goes.
I think
and it jumped. I think there was a nodule there with a plaque because it jumped there.
No, there's a fallacy that says that orbital does not have slow flow. Yeah, it does less slow flow than rota. But then remember, if you have lipid besides calcium,
then it will cause more slow flow.
There must have been lipid along with calcium.
Then it causes more slow flow.
If you have a diameter of more than 2.7 millimeters, unless you really have significant wire bias, OA is of no use. I don't think OA did anything in that proximal lesion. OA only caused a problem in the proximal lesion because it must have rubbed off some plaque rupture or a lipid. I think imaging was very important in this. Agree to what said.
Yeah.
So I would have put a balloon there, dilated that, done an imaging run, and then go on ahead.
But the microcatheter was not going. Maybe it could have gone. I'm not denying that.
One more question is, why did you crank it up from 80 to 120 when
in the distal?
No, but why you do that?
The site of the maximum.
Because the 120 does not, like rota and 120 does not mean that it penetrates properly. It's only for large vessels. 120 is meant only for large vessels. It's not for not crossing the lesions.
This was
so.
Yeah.
I have a couple of things over here. First of all, to start with, I mean, when we have a lesion where the wire is crossed and the microcatheter is struggling and it's a critical lesion, I think rota scores over every atherectomy tool. And I think a 1.5 rota would have been my treatment of choice to start with. Once I'd done that rotablator, I think it would be great to do the imaging and do it. I mean, whatever you did, I'm still wondering, why didn't you complete the procedure? I mean, after
with so much of inotropes and everything going on, I didn't want to risk further even a balloon dilatation or passing a microcatheter. I'd say so far he is good, he is recovering. Another 50, the flow is good. Another 15 days or 1 month would not have been a problem.
It could have gone worse. It got worse.
Kirti? Yeah. We were deciding to finish the case. Yeah, but with all that, I didn't do it. I'll take it. It's already 15 days now. Everything is fine. He's recovering and electively we'll do the procedure.
Kirti, one question from my side. Now, you saw that the lesion was very tight. Very often than not, we do what we dilate, as Kane said, you dilate with a 2 millimeter balloon and then put in your imaging catheter. Very often they would. And then if you find that there is a significant calcium, burden of calcium, either we do with rota or with OCT and take into consideration doing an IVL also, if it is there. But you said that the outcome does not come. I fail to understand why.
I'll tell you why. Because
unless you find that there is a dissection, a staining of the dye at the site where you have done the balloon dilatation. If that is so, yes, the outcomes are going to be many. You have to take it with a pinch of salt. What is going to happen in that case?
So when you start taking balloons in calcified lesions and trying to create small openings, the whole tenet, I mean, it came from some centers in Japan where they thought that if we were able to get a little bit of flow, then you'll have less ST segment changes with rotablator. I think there's a paper which says that. But the downside to that is whenever you take a 2O balloon and you start doing a balloon dilatation, very often you'll start breaking the softer side of a plaque, and not all these plaques are concentrically calcified. A lot of them have a soft tissue on one end, and you have made an opening on that soft tissue. Now you take a rotablator and do that, your burr gets entrapped in those dissections. We have seen this time and again that rota-related complications are more in these groups when your rotablator will daughter through and then it won't come back. That is a problem. And therefore, I feel that if you want to get the best result with rotablator, it is almost always best used upfront without any other technology.
No, Ajit, here the nothing was crossing. Even the microcatheter was not crossing.
We are not talking about these cases in general.
Sorry.
Yeah. There is no question that if it is rota is the first choice.
Sorry.
The other thing is always 360-degree arc of calcium means atherectomy or IVL is also not true, because it has to be more than 5 millimeter at least. That is what the literature says.
Thickness
right?
matters.
Yes, even an NC balloon with a 360 arc of calcium, if it is less than 5 millimeter, will crack. So not necessarily every time.
No, VT, the problem is not that. The problem is crossability. You are struggling to cross.
I'm saying of crossability. I'm saying when the balloon. See, I told you first thing. Balloon uncrossable means atherectomy, any of the three. I agree. Everybody agrees.
Great. So we'll discuss this.
Kani,
over...
one question to corroborate what he said.
Okay.
That if you have a significant calcium right round, you would go sometimes with a thin calcium, you can get away with a balloon dilatation. My question is, many a times you do IVUS or you do an imaging, you find that the calcium is just less than 180 degrees. And you get, okay, now I'm not going to use rotablation or any of the modifying devices for the calcium. I go with the balloon, the NC balloon, or maybe I go with the cutting balloon also. I find that the balloon opens very well in the two planes which I have taken. And then when I stent, and once I stent, I find that the calcium is pushing the stent onto the other side. This happens quite often.
Yes.
And then with overzealous way, you tend to go and open that with larger balloons and create problems.
Yeah,
This
that is
is
true.
the seduction of a balloon, and it should be avoided at all costs in uncrossable lesions.
No, I'm not talking about uncrossable lesion. I'm talking about a patient.
But Kirti, that doesn't mean 180 degrees arc of calcium means you use IVL.
No, absolutely.
Right or not?
No. No, I'm just telling you
Or
that
anything
don't.
else. No,
After doing, if you find that there is an indentation, and if you find
Correct.
because the stent is pushed
But,
onto the
Ajit,
side which is not having.
What
Listen
does
to me
imaging
first.
say? Imaging says if your areas are good, opposition is good, result will be
Yeah,
good.
absolutely. If you find that the MSA is good, then you don't go for
visiting
anything beyond that.
Yes. In stents, like if you get a good MSA.
Yes, absolutely.
And if it's not a round finish, if you get a D-shaped finish.
Yes.
It's
going
It's all right.
That's what I'm saying. Don't go overzealous and try to
So if
dilate
you get
with
a
the bigger
good
balloon.
lumen area,
Yes,
you are
absolutely.
supposed to accept
Correct.
the D-shape.
Absolutely,
Good lumen
yes.
with good opposition,
Yes,
fine.
yeah.
Any shape.
So now let's go ahead with our youngest star, Chirag Parekh, with a very, very interesting case. Chalo.
Thank you, sir. It's an absolute honor to follow all the stalwarts. I'm going to keep it very short. I think most of the things have already been discussed. I just want to highlight a particular technical aspect of orbital. So directly into the presentation is a 66-year-old male presented with effort angina of 3 months duration, risk factors of diabetes, hypertension, and current smoker. Had an evolved inferior MI on his ECG and underwent an angiography at a outside hospital, which showed a single lesion in the ostium of the RCA. And you can see it's a heavily calcified RCA with ostial 90% stenosis, and then what appears to be a calcific nodule in the proximal aspect. This is the only shoot that I have, because as soon as we were engaging the guide, there was a significant ventricularization of the trace and bradycardia. So we just engaged the catheter artery with the wire up front. So the left system had some non-obstructive calcific plaques, but nothing significant. So with this angio, we have three options. I think most of us would probably go with a rota ablation. There are few challenges. We would probably need an extra support wire and start burring with inside the guide. There are two problems. We cannot go with a extra support guide here with like a AL, and there is a risk of aortic injury when we start ablating from within the guide. Second option would be an IVL, but I think in this case there was a challenge whether the IVL would cross. We could do a balloon dilatation, but I am now more and more in Dr. Punamia's camp, where I feel we have landed up in more trouble with balloon dilatation. And the last option was orbital, although this was one of our initial cases and we had limited experiences. Theoretically, I thought this has some advantage in terms of if we can get across the lesion and do a retrograde sanding. Laser, we do not have in our lab. So just before starting the case, we did a review of literature, and this is one of the papers which showed the technique of orbital atherectomy in ostial lesions, and they have a case series of 50 cases. So unlike rota, there are certain challenges with orbital. When we do rota for an ostial lesion, we start burring from inside the guide and then advance the lesion, burr inside. In orbital, we cannot do that because it revolves, it will polish off the plastic within the guiding catheter. So the first thing that we need is we need to engage the crown into the vessel. And if we see the design of the orbital burr, there is a 6 millimeter nose cone before the crown. So they have described three techniques. The first one is have a guide and advance the orbital crown past the ostial lesion using the glide assist mode, and then start sanding in the retrograde direction. This will not happen in all cases, because if the lesion is very tight, you may just have a backing out of the guiding catheter. The next thing what you can do is you can try to just engage the nose cone into the lesion, and if you have the guide catheter which is coaxial, you can start burring in the antegrade direction. But for this, the nose cone, the first 6 millimeter has to engage the lesion. And after the initial pass, then you can consider a retrograde treatment. And the last thing is, if you cannot engage the nose cone, then consider a small balloon dilatation or a change of strategy and go with the rotational, sorry. So this is what we did. We had a JR guiding. We had already got a workhorse wire in, so we thought we'll exchange with a microcatheter, but the microcatheter would not go beyond the nodule. So keeping the microcatheter in place, we just got a wiper wire inside and got the wiper wire into the distal vessel. This was not a challenge. The next thing which we tried was a glide assist delivery of the crown beyond the ostial RCA lesion, but that was not possible. But what we can see is that we have got the nose cone engaged into the lesion and we have the burr up to the ostium. So we will not be sanding from inside the guide. So we did an initial run of antegrade sanding with a 80,000 RPM. This was a very slow run. Now another underappreciated part about the orbital is that it's not just the speed at 80 and 120. It's also how fast you advance the burr will decide how much of an arc it creates. So if you go slow, it will create a bigger arc. If you go fast forward, then it will create a smaller arc. So we decided to go at not as slow as what everyone says, because we did not want to create a very big arc here. We just wanted the crown to pass. And then once we got the crown beyond the lesion, then we did the further sanding in the retrograde fashion. And we did few runs with 80,000 retrogradely. So every time we would go on glide assist, go beyond the lesion and do the sanding in the retrograde way. And then we did further runs at 1,20,000 RPM. So this is, and I think after this we did IOS, but in interest of time, I think we'll just focus. I wanted to highlight this aspect of orbital in ostial lesions. And then it was the rest of it was pretty straightforward. We did the scoring balloon 3513 and then stented with a 3533 DES covering the ostium, post dilated with a 37512 NC balloon, and this was the final result. So this is the pre and that's the post. He's doing well. He's completed 6 months of follow-up, no restenosis. So that's my presentation. Thank you.
One question from my side, Kirti. If you have a calcific nodule, we know even with IVL, it does not give way. Many a times. Yeah, many a time. With orbital atherectomy, it shows a little more promising. Is there a specific technique when you do the orbital atherectomy to deal with these calcium nodules? I'm not talking about eruptive calcium. I'm talking about the other ones. Yeah.
So there's no technique. I think what you did exactly this. So only question is at bends, try to come back and reverse them. I mean, sand on the reverse. You can also do it antegradely like you normally conventionally do it. But as you get into larger arteries where the nodules are more relevant, I think you may have to focus on the area of the nodule with a larger speed. But when you do that, don't do that large speed all across the artery. Because
the segment.
Just that segment,
That's
you
what I'm
focus
asking.
and come back. Because if you start doing it on all across the artery, you disrupt a lot of soft tissue. And that is detrimental.
But as you see in his case also, even after doing the orbital at high speeds, the calcium probably is still there, the nodule.
So, I don't know what, I mean, I would love to have Ganesh and Ronnie's view on this as well, but for me, this kind of a case is a rotablator 1.5 followed by 1.75.
Absolutely.
That's far more effective in this.
Because I'm more concerned about the aortic dissection occurring here.
Extrapolating the same thing what you're saying.
Yeah.
In your case, in the circumference,
Yeah.
it didn't open. So,
Yeah.
with orbital,
outside
at that point.
So I'd already done 120 over there because I knew from I already knew from my CT that that's an issue. So at that area I did do a few runs with 120. But the problem with orbital is that not every time we are able to avoid the use of an IVL when it is going to be required. Whereas if many a times you and I both have seen, you do a 1.5 rotablator, you do a 1.75, then do a cutting balloon, and obviously something that would have been an IVL, you don't need it. But in the orbital, I have not, maybe it was that early experience, so we were not aggressive enough, but...
sometimes it's not the orbital to exactly position at that place.
The ostium, yeah, absolutely. I'm in orbital with the thing vibrating so much. I'm concerned about the aortic dissection occurring there, at the ostium. So, and particularly if you have calcium and if the orbital device doesn't go through, then it's going to be a problem for me.
Aortic dissection in ostial lesions is almost always because of injections in a ventricularized artery. So if you avoid injecting into this artery, I don't think that will happen. Really, I'm not kidding. It's almost always. I mean, every time you see aortic dissection retrogradely coming, it's from an injection which has gone in a plane and our dissection has propagated.
Chirag wants to say something.
Absolutely. No, I'm talking about situation where the thing does not go through because it looked to be quite a tight lesion in this situation.
Yeah, it can probably dissect, obviously.
Chirag, there is a little bit of an issue. I sometimes feel that when you get your guide, especially when you're doing proximal RCS and you're doing atherectomy, orbital or rotablator, you need to take your guide away from the ostium. Yeah. And the reason you need to do that is when you take your guide very close to the ostium, you kind of make that entire device extremely stiff. And two, guide catheters reduces flow. So the burr or the orbital or the rota tends to get very hot very soon and you're likely to get stuck burr. So particularly when I do ostial RCS, I get it coaxial, but then I take my guiding catheter back and let blood flow around the so
Plus,
my
I
dear-
think it will. You,
so I
you
think
may miss
Kirti-
on the tightest spot in the ostium.
Kirti,
if
your
you
point
keep
is
it
very
wedged,
well
yeah.
taken because
So we'll go ahead.
with the forward propelling, which is rotablation, I think you can pull the guide. It does not require guide support once the wire has gone. So it makes
thank you.
things very easy.
Yeah. Thank you, Ajit. Thank you, Kirti, and thank you everybody for all these presentations. I have just to make a small request. Please don't move from here. We are now going to shift gears altogether. Just to keep everybody happy, our main sponsor is Sun Pharma along with Abbott. So we will have a small presentation, and I have requested our secretary to make that. Bempedoic acid current status. And to chair the session, we have Dr. Bhupen Desai and Dr. Shilpa Kadam. Can you just come in front, madam? Yeah. So just don't move. I would request everybody just please keep sitting. And so Dr. Sadanand Shetty, he's come. Okay, I didn't say it.
Thank you very much. And it's, of course, I don't want to stand for long between lunch and all of you, but a very apt time to discuss about lipid lowering therapy after seeing all those fancy instruments and ghastly disease. We don't want them coming into us. Probably good lipid management will help in that. We'll be very quick and brief. Atherosclerosis is a clinical paradox because potentially it's a very preventable or treatable chronic disease, but yet it remains the greatest cause of disability and death. We know the association of cholesterol with myocardial infarction and death for almost more than 100 years. And since more than 30 years, we also know that the cholesterol starts accumulating from a very young age and not at the time when the patient presents with an acute coronary syndromes. We have identified so many modifiable risk factors which can lead to a coronary artery disease, and we have identified that lipids or LDL is one of the worst of all of them. We have also learned that if you reduce LDL cholesterol even by 1 millimoles, you are going to reduce the cardiovascular risk by 20%. And recently we have learned that if you have an intensive lipid lowering therapy with and PCSK9, then we can convert a vulnerable plaque into a stable plaque by reducing the lipid core and increasing the fibrous content. We also have data which shows us that if you have a very low LDL cholesterol, less than 1.9 millimoles, then probably there is a chance of a plaque regression which is higher. And if you have very high lipids, then of course the plaque is going to progress. We all know that cholesterol is essential, but we forget that LDL cholesterol is not essential. LDL cholesterol is a transport thing, and we should be aware that every cell in the body has the capability to produce cholesterol what it needs for its metabolism and for its growth, and it's not necessary that LDL should be there. We have also learned from experience from thousands of patients that when you reduce LDL cholesterol, we have a significant reduction in all these MACE events. We've learned that lower is better, and we still keep going lower and lower. Probably 30 or 40 milligrams probably is the ideal goal. We don't know. This was a study from Scott Grundy 20 years back. We know that there is a safety of LDL cholesterol as low as 25 milligram% without having any problems. We know that in neonates, they are born with a cholesterol of 20, plus or minus 10, not plus 10, plus or minus 10. And yet they have an extremely good development. Everybody grows well with a good neurological development also. So LDL cholesterol being necessary, definitely not so. Dr. Braunwald himself has written this beautiful article, Race to the Bottom for Cholesterol, and he has said that even ultra low levels of LDL cholesterol, this 0.3, which is less than 15 milligram%, can be safe and is well tolerated. Despite knowing all these things, we still let the acute coronary syndromes and coronary artery disease be the leading cause of death and mortality and morbidity in this world. Despite knowing all this, LDL cholesterol still is not well treated, and we can see from the bottom here, this yellow is the people where there is a no, and that means most people do not know that they have high cholesterol, and even if they know, only 1/3 of them are going to start therapy, and even if they start therapy, only 1/5 of them are going to achieve the target levels. one of the easiest way to achieve a good cholesterol reduction is by increasing the statin dose. That is all what we all think, but sometimes it is not possible. We know that most of our patients, or not most, but many of our patients get some form of a statin-associated muscle symptoms. Most of the time they are not significant, but somehow when you have a muscle symptom, patients tend to reduce their dose or altogether stop the therapy. So this is very important. And we know that almost 22% of statin users get some sort of a statin-induced pain. And only a very few of them actually continue and achieve the goal of a low cholesterol level. So these are some of the unmet needs of current therapy. We know that statin has its own problems. Ezetimibe can have GI problems. PCSK9 is very good but very expensive, and also need an injectable therapy. So we do have a need for some other oral drug, and that's where bempedoic acid comes in. This is the molecule which we are going to discuss in brief now. And we all know that bempedoic acid acts only in the liver. That's really very important. It acts only in the liver, and it acts in the same pathway but a step prior to where the statins act before the HMG-CoA kicks in. It is very important to know that bempedoic acid is a prodrug. It is not active, and it needs a ACSVL1, that is a coenzyme, is necessary to convert this into the active form. And this ACSVL1 is present only in the liver and not in the muscles. So that is why bempedoic acid reduces the cholesterol synthesis only in the liver and does nothing in the muscle, and that is why the muscle side effects are really very low. That is what is believed. So here we have one of the first trials for the use of bempedoic acid, and this is by Csi Ray in 2019, which showed that they randomized almost 2,000 patients to 2:1 to 180 milligram of bempedoic acid once a day versus placebo. And they found that at the end of 1 year, if you add bempedoic acid to a maximally tolerated statin dose which they are already taking, then you lead to a significant reduction in LDL-C levels, and also the side effects are not significant. Then there were a host of clear trials, this Harmony and Wisdom, where the patients were given bempedoic acid on top of their maximally tolerated statins, and here the other two, the Tranquility and Serenity, where the patients were intolerant to statin and only bempedoic acid was given. And you can see that a significant reduction, almost an average of 18 to 20% reduction in LDL-C levels. Then the question was whether there is some outcome data, whether the MACE rates are also reduced. So we have a trial which came 2 years back, again from the same group, Steve Nissen and Csi Ray. And here they followed the patients for 5 years. And they found that for 5 years, if you give bempedoic acid, your LDL cholesterol levels significantly lower, your HSCRP levels are also low, and most importantly, you have MACE levels which are significantly lower. Whether you consider a 4-point MACE, a 3-point MACE, whether you consider myocardial infarction, both fatal and non-fatal, and episodes of coronary revascularization, they all are reduced when you use bempedoic acid as compared to placebo. Bempedoic acid does have some side effects, and we can see that muscle pains are also there, but this is something very negligible. You can see as compared to placebo, muscle spasms 3% versus 2%, hardly there. Pain in the back, pain in the limb, again 3% in a bempedoic acid branch, and only 2% in the placebo group also. And then you have a small percent of patients where the uric acid goes high, and somebody will have some GI problems like diarrhea. One important and serious adverse effect which is found in 0.5% of the patients is the tendon ruptures, and the tendons which were involved were the rotator cuff, the biceps tendon, and Achilles tendon. And of course these are something really important, but comes in a very, very small number of patients, so we don't know what is the exact mechanism of that. Then bempedoic acid was used with ezetimibe, as a fixed dose combination, and it was found that this combination is well tolerated and reduces the LDL levels significantly. Then came the idea of triple therapy. Now we know that in most of our other diseases also, combination therapies are preferred over single high dose therapy. And this paper came out again 5 years ago, and which said that when you use a combination therapy of atorvastatin plus ezetimibe plus bempedoic acid, there is a significant reduction of 60% as compared to placebo, and almost 90% of these patients achieved their target LDL levels. So of course there was a criticism of this trial because this was a triple therapy versus placebo, unlike a triple therapy with a single statin or a dual combination. So that was something which was criticized, and also they were using only lipid levels and no mortality or MACE endpoints. However, because each and every of these three drugs have been proven their efficacy in as far as outcomes are concerned, so probably if you combine all these three together, we are going to have a good outcome. We'll have to wait for some data to come for that. And also when you combine all these three into one polypill, you can improve the compliance. Then there came a meta-analysis of bempedoic acid, either monotherapy or combination therapy, and again shows a favorable effect of reduction of LDL cholesterol, and not only a favorable effect, but there's stronger reduction when you use a combination. So if you use a combination drug, you have almost a very high reduction in LDL-C levels. So with that, there is an advocacy for using a combination therapy for treating high-risk patients for LDL reduction. And the latest guidelines, the ESC guidelines, which have come 1 month back, which is a 2025 focused update of the guidelines which were released in 2019, and they have now increased or rather lowered the LDL-C target levels, and you can see that if you have even a low risk patient, then 116 is your target for LDL. If you have moderate risk, then it is less than 100. If you have a high risk, then less than 70. A very high risk, the LDL target is less than 55. And now they have a new risk category, that is the extreme risk, in which the target is less than 40 milligram per percent. And this is a very nice slide. It appears very complex, but it's really nice. I'll just tell you through this. And here on the left side, you can see if you start only a moderate intensity statin, you have a 30% reduction of LDL cholesterol. If you increase it to a high intensity statin, it's a 50% reduction. If you use ezetimibe alone, 20%, bempedoic acid, 23%. When you combine ezetimibe and bempedoic acid, you can have a 38% reduction in LDL. And if you combine a high intensity statin with bempedoic acid and ezetimibe, a phenomenal 68% reduction in LDL cholesterol levels. And of course, if you add PCSK9, then you can have further reductions. And if you use PCSK9 plus, on the right hand side, you can see high intensity statin, ezetimibe, bempedoic acid and PCSK9 all together, then 86% reduction in LDL cholesterol levels. That's really phenomenal. And now this new focused update gives a class 1 recommendation for initiating non-statin therapies, including bempedoic acid, in patients who are unable to take statin therapy to reach their goals. And also it gives a class 2A indication to add bempedoic acid if the patient can take a statin but does not reach the goal with the maximally tolerated statin. So the take-home messages: cholesterol though is essential, LDL cholesterol is not essential. We can safely keep it very low. We should start LDL lowering therapy as early as possible and continue for as long as possible. Use very high intensity statins for acute coronary syndromes and continue for a long time. Serious adverse effects do occur, but they are not very common. Some side effects, minor side effects of course can come. Ezetimibe and bempedoic acid are safe, and combining 2 or more drugs together not only is safe but adds to the efficacy of the drugs. Thank you.
Thank you, Bhavish. After this all those heroic topics, In fact, I also thought Kane Bempedoic was a misfit, But crisp, very presentation. Unfortunately, only thing, you have not mentioned anything about the LAI, Now, Lipid Association of India is there for last 12 years, and our target, everything, I'm just saying, one, there are trial, where you have done that what you showed is the triple is not the clinical, the phase 2 study,
Yes.
We have a LA REACT study where we have showed, using 3 in acute coronary syndrome, what is the benefit, how fast we should reduce and all. See, one important thing for all of you here, our dyslipidemia is different than the Western. That you have to accept first. Our average LDL is 10 milligram less than the Westerners. Our consensus, our whatever statement we are giving, we have to follow that. What European, now 25 they mentioned, LA has mentioned 4 years ago. For all of you, I can give the LA consensus 24 data. In fact, in our forum, I am writing every time, Our LDL level, because 10 milligram average less, and it's been studied. ECO Biobank, Interart study, a lot of international study, because our basal LDL should be less than the what target they give. Extreme risk category was mentioned about 4 years back by the LAI. Now we have kept 3 category. There is a place to reduce LDL even to 15 to 20 also. But anyway, the time is, because the topic and the time is a problem, but it's a good presentation, I would say. So Bempedoic, basically, has an important role in our 2 indication where you have to use Bempedoic. 1, and we have written few years ago in JAPI, unmet need of LDL lowering. When the LDL lowering with statin and ezetimibe is not there, use Bempedoic. And the second indication where statins are not tolerated at all. So when patient cannot tolerate at all, we know this. And for primary prevention, Bempedoic do not have too many studies in here.
I think time is running short, so we'll conclude. The take-home message is, if you use 3 combinations, that is high-intensity statin, ezetimibe, and bempedoic acid, you will achieve 68% reduction. Only thing you have to worry about is gout. I think there are no more questions from the crowd. So you have?
Okay, I have to propose the vote of thanks, please, before you all go. Okay, sorry. You said it's concluded. Okay.
Sorry.
Okay.
Extremely sorry to delay. Extremely sorry to delay. I would like to know how many of us have seen tendon rupture with bempedoic acid?
No.
They have mentioned in the literature, but as far as I know, I have not seen it.
Can I ask one question?
Sir, you had closed the session. Now you are asking.
Any questions from the crowd? Any questions?
Okay, so I propose a vote of thanks as a secretary of Mumbai branch of CSI.
Vote of thanks.
It is my pleasure and privilege to give a vote of thanks. First of all, I would like to thank our speakers, Ronnie Matthew and Girish Navasundar, who come all the way from out of Mumbai on a Sunday morning. Thank you very much for some excellent presentation and sharing your knowledge with us. We learned a lot from this. And I want to thank all the case presenters, Dr. Ajit Menon, Dr. Nagesh Wagmare, Zakia Khan, Kirti Purnamia, Anand Rao, Viti Shah and Chirag. And of course, thanks to all the chairpersons and all the moderators. Most importantly, a big thanks to Dr. Kane and Dr. Amit Sanghvi for making this program. And thanks, most importantly, thanks all the sponsors, Abbott for this wonderful presentation, and Sun Pharma for this nice arrangements which they have made for us. And now we can proceed for lunch. Thank you very much.